A 40-year-old musician named Anne Marie comes to the primary care clinic. She mentions that multiple lumps in her breast would come and go at different times during her menstrual cycles. For the past year, she has also experienced premenstrual breast pain in both breasts. On physical exam, multiple lumps were found on the upper outer quadrant of the right breast. At the same time, Ashley, who is a 32-year-old rehabilitation technician, comes to the clinic because of a breast lump that she noticed 8 weeks ago. She reports that a lump seems to become more tender and increase in size during her period. Physical examination shows a palpable, mobile, firm mass in the right upper quadrant of the right breast. At first glance, you think Anne Marie and Ashley have similar problems, but the fact is they have different forms of benign breast conditions. Now these include fibrocystic breast changes, benign tumors such as fibroadenoma, intraductal papilloma, and Phyllodes tumor, inflammatory processes such as fat necrosis and lactational mastitis, and gynecomastia. On your exams, it's important to differentiate these from possible malignancy based on presentation, history, and other findings. First, let's start with fibrocystic breast changes, which are the most common benign lesions of the breast that are typically found in premenopausal women between 20 to 50 years of age. These individuals usually complain about premenstrual breast pain, which is a very high-yield fact and the hallmark symptom of this condition, and multiple lumps, which are typically located in the upper lateral quadrant of the breast. But often, these lesions can be bilateral and multifocal. Another high-yield fact is that the breast pain and lumps are associated with the phases of the menstrual cycle and cyclic ovarian hormonal stimulation. Fibrocystic breast changes can include simple cysts, which are dilated and fluid-filled ducts, papillary apocrine change or metaplasia, and stromal fibrosis. Now, cysts and fibrocystic breast changes can be clear or blue-domed due to a light yellow fluid that gives the cyst a blue color when seen through the surrounding tissue. Remember that fibrocystic breast changes are generally not associated with an increased risk of breast cancer, but there are two subtypes of this condition that are linked with a slightly increased risk for cancer. The first one is sclerosing adenosis, which is the subtype characterized by calcifications and the proliferation of small ductules and acini in the lobules. The second one is epithelial hyperplasia of cells in terminal ducts and lobular epithelium, which is associated with an increased risk of breast cancer only if there's a presence of atypical cells. Either way, you should always order mammography to rule out malignant disease in these individuals. Finally, the mainstay of the management of fibrocystic breast changes is conservative treatment, while iodine supplementation is thought to be of benefit in some individuals with this condition. Now let's focus on benign breast tumors. First, there are fibroadenomas, which are the most common breast tumors. They arise from the periductal stromal tissue and are typically seen in premenopausal women under 35 years of age. Fibroadenomas are usually asymptomatic and they are discovered on screening exams. On your exam, you should suspect fibroadenoma in a young woman with a small, well-defined, spherical, painless, mobile breast mass. Moreover, it's so mobile that it's often referred to as the breast mouse. On the other hand, in older women, the tumor is usually identified as a mammographic density with possible calcifications. Generally, these tumors are solitary lesions, but some individuals can present with multiple fibroadenomas, which can occur in both breasts. Histologically, fibroadenoma of the breast is characterized by an overgrowth of cellular and often myxoid stroma that surrounds and occasionally compresses epithelium-lined glandular and cystic spaces. As women age, stroma becomes more hyalinized while the glandular epithelium atrophies. These tumors can range in size from 1 to more than 10 centimeters. A high-yield fact to remember is that due to their estrogen sensitivity, they can increase in size and tenderness during the luteal phase of the menstrual cycle and lactation. Individuals with fibroadenoma are usually not at risk for developing breast cancer, but they should undergo mammography and ultrasound to exclude malignancy. Therapy is often unnecessary because these tumors typically regress with menopause, so the mainstay of the management is observation and reassurance. On the other hand, some individuals can undergo cryoablation, which is a non-invasive method of treatment that utilizes low temperature to decrease the size of the tumor. Next, we have intraductal papilloma, which is a small, benign, fibroepithelial papillary tumor within the lactiferous ducts of the breast. This tumor is most commonly found just beneath the areola, but according to its site of origin, it can be classified into central intraductal papilloma, which typically presents as a single lesion, and peripheral intraductal papilloma, which usually presents as multiple lesions. Typically, these lesions are small and cannot be seen on the skin or palpated. However, you have to remember that intraductal papilloma is the most common cause of serous or bloody discharge from the female breast. This discharge is usually unilateral and not associated with breast masses or regional lymphadenopathy. Another high-yield fact to know is that young premenopausal women under 35 years of age are at increased risk of developing intraductal papilloma. Unlike the previous conditions, intraductal papilloma is associated with a slightly increased risk of developing breast cancer. So remember, in a woman with bloody nipple discharge, you need to perform a biopsy to rule out papillary carcinoma, which is an important differential diagnosis of intraductal papilloma. As far as diagnosis goes, mammography is not used for visualizing the site of intraductal papilloma since it's too small to be detected. Instead, the most specific imaging modality for the diagnosis is galactogram, which is a diagnostic procedure used to visualize the breast ducts. Finally, microductectomy is a procedure performed for the management of intraductal papilloma and excision of the lactiferous duct. Moving on to Phyllodes tumor. The name of this tumor comes from the Greek word phullon, which means leaf. Histologically, it's characterized by a large mass of connective tissue and cysts with leaf-like projections. It typically arises from the periductal stromal cells. This tumor typically presents as a painless mass in the breast, and it's most commonly seen in postmenopausal women. Moreover, the breast mass associated with Phyllodes tumor can resemble a fibroadenoma, but has a faster growth rate, often showing noticeable growth from week to week. For your exam, you have to know that a Phyllodes tumor can become malignant. They appear as well-circumscribed lesions on mammograms, but the diagnostic tool of choice is a core needle biopsy. Axillary lymph node dissection is not indicated for individuals with this tumor. Finally, the best initial management of Phyllodes tumor is surgical excision. Now, switching gears and moving on to inflammatory processes. First, let's start with fat necrosis of the breast, which is a benign, non-suppurative inflammatory lesion that occurs when an area of fatty tissue gets damaged. It's important to note that up to 50% of individuals with fat necrosis of the breast don't report breast trauma, but on your exams, this could be the best clue. On physical exam, you will detect a breast lesion that presents as a painless fixed mass with possible skin or nipple retraction. Fat necrosis of the breast is diagnosed by mammography, which shows calcified oil cysts, and biopsy, which shows partially necrotic adipose tissue with foamy macrophages and multinucleated giant cells. The next one is mastitis, which is an inflammation of the breast parenchyma. This usually leads to swollen, red, and painful areas on the breast, and sometimes fever. Lactational mastitis occurs during breastfeeding and is most commonly caused by Staphylococcus aureus entering through cracks in the nipple. For your exam, it's crucial to remember that breastfeeding should continue during an episode of mastitis. Next, there's periductal mastitis, a type of mastitis that involves vitamin A deficiency that results in squamous cell metaplasia of the lactiferous ducts, causing blockage of the duct and subsequent inflammation. This type of mastitis is commonly seen in smokers. Finally, mammary duct ectasia is a rare cause of mastitis, where inflammation and fibrosis cause blockages in subareolar ducts, causing them to dilate. This blockage causes fluid buildup in the duct, which can lead to bacterial mastitis. Individuals with mammary duct ectasia present with a periareolar mass and a green-brown nipple discharge that is a result of inflammatory debris and bacteria. Since S. aureus is the most common pathogen causing lactational mastitis, antibiotics such as amoxicillin, clavulanate, cephalexin, or ciprofloxacin Clindamycin and trimethoprim sulfamethoxazole are often used to treat these individuals. The last condition is gynecomastia, which is a benign breast enlargement in males due to increased estrogen activity and decreased androgen activity. This enlargement is caused by proliferation of glandular tissue, and it can be unilateral, bilateral, or present as a mass around the nipple area. Based on the cause, gynecomastia can be classified into idiopathic gynecomastia, where the cause is unknown, physiologic gynecomastia, which is commonly seen in newborn males due to the mother's estrogen, or the elderly males due to decreased androgen production, but it can also be seen during puberty. Pathological gynecomastia can be seen in cirrhosis, where there's increased conversion of androstenedione to estrogen, and testicular germ cell tumors can secrete HCG that also has a similar effect. Next, hypogonadism, like in people with Klinefelter syndrome, can decrease androgen production. Also, pathological gynecomastia can be caused by medications, such as spironolactone, which converts testosterone to estrogen. Next, hormone therapy for prostate cancer uses anti-androgen agents like bicalutamide, which can also cause gynecomastia. All right, as a quick recap, fibrocystic breast changes arise from within the glands and are the most common benign lesions of the breast, which are typically found in premenopausal women 20 to 50 years of age. Key findings include premenstrual breast pain and single or multiple lumps, which are typically located in the upper lateral quadrant of the breast. Fibroadenoma is the most common breast tumor, which is most commonly seen in premenopausal women under 35 years of age. This tumor presents as a small, well-defined, spherical, painless breast mass that's highly mobile in younger individuals. Intraductal papilloma is a small, benign, fibroepithelial papillary tumor within the lactiferous ducts of the breast, usually found just beneath the areola, while Phyllodes tumor is histologically characterized by a large mass of connective tissue and cysts with leaf-like projections. Next, inflammatory processes of the breast include fat necrosis, which is a benign non-suppurative inflammatory lesion that occurs when an area of fatty breast tissue gets damaged, and mastitis, which refers to an inflammation of the breast parenchyma. Moreover, lactational mastitis occurs during breastfeeding, and it's most commonly caused by Staphylococcus aureus entering through cracks in the nipple. Finally, gynecomastia is benign breast enlargement in males due to increased estrogen activity and decreased testosterone activity. Now let's go back to our cases. Anne-Marie noticed multiple lumps in her breast that would come and go at different times during her menstrual cycles. Also, she complained about premenstrual breast pain. Therefore, we should assume that Anne-Marie has fibrocystic breast changes. On the other hand, Ashley noticed a breast lump that becomes more tender and increases in size during her period. In other words, she has an estrogen-sensitive breast condition. In combination with a physical examination, which showed a palpable, mobile, firm mass in the right upper outer quadrant of the right breast, we can assume Ashley has fibroadenoma. Finally, we should explain to Anne-Marie and Ashley that their conditions are not associated with an increased risk of breast cancer, but either way, we should order mammography to rule out any breast malignancies.
"26-year-old Effie is brought to the emergency department with severe lower abdominal pain and bloody vaginal discharge that began a few hours ago. Her last menstrual period was 7 weeks ago. She has been sexually active with multiple partners and uses condoms on occasion. Her past medical history is significant for pelvic inflammatory disease. On examination, her blood pressure is 80/40 millimeters of mercury, and her pulse is 130 beats per minute. She is pale, and her extremities are cold and clammy. Next to her, there's also 37-year-old Kate, who came in noting an abrupt onset of abdominal pain and continuous vaginal bleeding. She is going through week 28 of her 4th pregnancy and was involved in a car crash a couple of hours ago, but did not immediately seek medical care. On presentation, fetal heart rate and movement are significantly diminished. Laboratory studies reveal low platelets, prolonged PT and PTT, and elevated D-dimers. Peripheral blood smear shows schistocytes. Based on their initial presentation, both Effie and Kate have a form of pregnancy complication. Now, the most common medical complication of pregnancy is hypertensive disorders of pregnancy. These are diseases that cause high blood pressure during pregnancy, either a systolic blood pressure higher than 140 millimeters of mercury, or a diastolic blood pressure higher than 90 millimeters of mercury, or both. So when hypertension is diagnosed before 20 weeks gestation, it's usually chronic hypertension, meaning that it's not due to pregnancy. After 20 weeks gestation, new onset hypertension without proteinuria or damage to other organs is gestational hypertension. Now, if hypertension gets severe, meaning systolic blood pressure of 160 millimeters of mercury or greater, and or diastolic blood pressure of 110 millimeters of mercury or greater, it can often lead to organ damage. One key thing to look out for is the presence of proteinuria, or excessive amounts of protein in the urine, which is a marker of kidney damage. Other affected organs include the brain and liver. Now, if the hypertension coexists with proteinuria or other organ dysfunction, then it's called preeclampsia. Preeclampsia is more common during a person's first pregnancy, in pregnancies with multiple gestations, or in mothers 35 years or older. Other risk factors include having pre-existing hypertension, diabetes, chronic kidney disease, or autoimmune disorders like the antiphospholipid syndrome. The exact reason why preeclampsia develops is unclear, but a high-yield pathophysiologic feature, though, is the development of an abnormal placenta. Normally, during pregnancy, the spiral arteries dilate to 5 to 10 times their normal size and develop into large uteroplacental arteries that can deliver large quantities of blood to the developing fetus. In preeclampsia, these uteroplacental arteries undergo fibrosis, causing them to narrow, which means less blood gets to the placenta. This hypoperfused placenta starts releasing pro-inflammatory proteins. These then get into the mother circulation and cause the endothelial cells that line her blood vessels to become dysfunctional. Endothelial cell dysfunction causes vasoconstriction or narrowing of the blood vessels and also affects the kidneys in a way that makes them retain more salt, both of which result in hypertension. Vasoconstriction will also lead to reduced blood flow to the kidneys, which are particularly susceptible to ischemia and can cause glomerular damage, leading to proteinuria. The high blood pressure can also cause placental abruption, where the placenta detaches prematurely from the uterine wall. Next, the increased pressure inside blood vessels can cause endothelial injury, which leads to the formation of lots of tiny thrombi in the microvasculature. This process uses up massive amounts of platelets, so there's an increased risk of bleeding. To make things worse, these tiny blood clots are like large rocks in a river and damages the red blood cells trying to move past them. So, there's extrinsic hemolytic anemia. Specifically, red blood cells get split into smaller fragments called schistocytes. And bear in mind that these schistocytes are visible on peripheral blood smear. If all this wasn't bad enough, the thrombi can block blood flow to the liver, causing severe liver injury, which can cause an elevation in liver enzymes. Together, all these make up HELP syndrome. H for hemolysis, EL for elevated liver enzymes, and LP for low platelets. The damaged liver swells up, and in some cases, as the condition worsens, the liver capsule may rupture, leading to a subcapsular hematoma. This can present as right upper quadrant or epigastric pain. But if a lot of blood is lost, it can also lead to severe hypotension. Now, in other cases, HELP syndrome can develop into disseminated intravascular coagulation, or DIC. That's because damage of the endothelium can lead to the release of tissue factor, which triggers the coagulation cascade. And this, except for platelets which are already low, also depletes coagulation factors, making it even harder to establish hemostasis. This may present as bleeding from mucosal surfaces, intravenous lines, or incision sites, if there are any. Now, what's high yield is that in terms of lab work, remember there's decreased coagulation factors, which means a prolonged prothrombin time, or PT, and prolonged partial thromboplastin time, or PTT. Another important hint is elevated D-dimer levels, which come from clot lysis. So, an individual with HELP plus prolonged PT and PTT and elevated D-dimers is having DIC. Finally, endothelial injury in preeclampsia increases vascular permeability, which is when water is allowed to slip out of blood vessels between neighboring endothelial cells and get into the tissues. Because there's also a loss of protein from the blood due to the proteinuria, even more fluid moves from the blood vessels into the tissues, and this causes generalized edema, which is often seen in the legs, face, and hands, pulmonary edema, which can cause cough and shortness of breath, and cerebral edema, which can cause headache, confusion, and seizures. For your exams, what's high yield to remember is that when a female with preeclampsia develops seizures, we call it eclampsia. Alright, now let's discuss treatment. The antihypertensive medications that can be used for chronic hypertension in pregnancy or gestational hypertension are hydralazine, methyldopa, labetalol, or nifedipine. To remember this, you can use the mnemonic Hypertensive Moms Love Newborns. In preeclampsia and eclampsia, in addition to antihypertensives, IV magnesium sulfate is also given to prevent or treat seizures. But since all of the problems of preeclampsia and eclampsia stem from placental dysfunction, it's important to know that the definitive treatment is delivery of the fetus and placenta. Especially in the case of eclampsia or HELP syndrome, delivery has to be immediate. Okay, next, there's gestational trophoblastic disease, which includes both benign and malignant proliferations of placental or trophoblast cells. At the benign end of the spectrum, there's molar pregnancy, which is also called hydatidiform moles. At the malignant end, there's invasive moles, which can arise from benign moles, and choriocarcinoma, which is placental cancer that most frequently occurs in the absence of a molar pregnancy. Now, moles result from errors in normal fertilization. Normally, at fertilization, a single egg with 23 chromosomes fuses with a single sperm with 23 chromosomes, resulting in a new cell with 46 chromosomes. This can go wrong in two ways, so we have two kinds of moles: complete or classic, and incomplete or partial mole. Both lead to an abnormal proliferation of placental or trophoblast cells. The difference is that a complete mole appears when a chromosomally empty egg fuses with a normal sperm, and the sperm genetic material duplicates to form a 46 chromosome cell. However, it doesn't have both maternal and paternal chromosomes, so the mole develops into a mass, rather than developing into a fetus. An incomplete mole, on the other hand, appears when a normal egg is fertilized by two sperm, which forms an organism with 69 chromosomes that usually develops into non-viable fetal parts. What's extremely high yield is that with a complete mole, the placenta secretes a huge amount of HCG. So affected females initially present with signs of pregnancy, like missed periods. Vaginal bleeding is another sign, which may range from light spotting to heavy bleeding, and parts of the mole may even be eliminated, and they look like grapes or cherry-like clusters. Additionally, for unclear reasons, this huge amount of HCG can lead to early preeclampsia, meaning hypertension and proteinuria before 20 weeks of gestation. Don't confuse that with chronic hypertension, which is hypertension without proteinuria before 20 weeks of gestation. At the same time, excess HCG can lead to hyperemesis gravidarum, which is extreme nausea and vomiting, which can lead to severe dehydration. Interestingly, HCG has a subunit that's similar to TSH, so it can cause symptoms of hyperthyroidism, like insomnia, anxiety, tachycardia, and palpitations. Too much HCG can also result in the growth of theca lutein cysts in the ovaries, which can cause symptoms like pelvic pain or pressure on the affected side. Finally, since the mole grows much faster than a normal pregnancy would, a physical examination shows a uterus that's too big for gestational age. Histologically, we'll see finger-like projections called chorionic villi, which contain tiny arterioles and venules. Now, most villi will be hydropic, meaning swollen and edematous, and all around the villi there will be diffuse and circumferential proliferation of large trophoblast cells. These can be either cytotrophoblasts with central nuclei and pale cytoplasm, or syncytiotrophoblasts that have multiple nuclei and darker cytoplasm. Another thing we can do is stain for the p57 protein. This is produced by a gene that's only expressed on maternal cells, so a complete mole will stain negative for p57. Now, a very high-yield test result you must remember is that a transvaginal ultrasound will show no fetal parts. Instead, there will be a diffuse echogenic pattern called snowstorm pattern, sometimes described as looking like a cluster of grapes. This results from the presence of abnormal placental villi and blood clots that accumulates in the uterus. An incomplete mole also secretes more HCG than normal, but not quite as much as a complete mole. So while missed periods and vaginal bleeding are present, the uterus is not larger than expected for gestational age, and there are no symptoms of HCG hyperstimulation, like early preeclampsia, hyperemesis gravidarum, hyperthyroidism, or ovarian cysts. On histological examination, we'll also see villi, but unlike complete moles, only some of them will be hydropic. Another key distinction is that p57 staining will be positive. On a transvaginal ultrasound, fetal parts will be visible. Treatment for both complete and incomplete moles is uterine evacuation through suction curettage and methotrexate. Methotrexate is very frequently tested, so it's important to know that it is an anti-metabolite medication that is structurally similar to folic acid and is toxic to the rapidly dividing cells of the embryo. For your test, remember that it's essential to monitor the HCG levels afterwards until they go back to normal. If that doesn't happen, we can suspect an invasive mole or choriocarcinoma. Okay, so a high-yield fact is that both complete and incomplete moles are benign conditions, but can develop into malignant tumors, like invasive moles, or in rare cases, choriocarcinomas. In invasive moles, the villi invade deeper into the myometrium, which is the muscular wall of the uterus. In fact, complete moles have a 15 to 20% risk of developing into invasive moles, whereas with incomplete moles, the risk is under 5%. However, it's high yield to know that most choriocarcinomas develop during or after a non-molar pregnancy. Broadly speaking, choriocarcinomas are usually quite small, but if they get large enough, they can present with lower abdominal pain or pressure. They are also extremely aggressive, so they have a high chance of spreading via the circulation. A high-yield fact is that a very common location for metastasis is the lungs, causing shortness of breath and hemoptysis. On a chest X-ray, this shows up with the characteristic cannonball metastases. These are multiple, large, well-circumscribed, and round metastatic masses. Metastatic disease to the brain may also cause headache, dizziness, nausea, slurred speech, or visual disturbances. Just like benign moles, choriocarcinomas also secrete HCG, and this can cause symptoms of hyperthyroidism, as well as bilateral, multiple, theca lutein ovarian cysts. For your test, remember that under the microscope, choriocarcinomas look very similar to moles. So, they have cytotrophoblasts and syncytiotrophoblasts, but the key distinction is that there are no villi. The main treatment is methotrexate. Alright, now let's look at ectopic pregnancy. Normally, a fertilized egg travels through the fallopian tube and implants in the uterus. But in an ectopic pregnancy, the fertilized egg ends up implanting somewhere else. For your exams, remember that the most common site is the ampulla of the fallopian tube. But it can also occur on various surfaces, like the ovaries. The cause of an ectopic pregnancy is often unknown, but there are well-known risk factors. A very high-yield one is pelvic inflammatory disease, since the inflammation results in scarring and adhesions, particularly in the fallopian tubes, thus blocking the fertilized egg from traveling down into the uterus. Scar tissue can also build up in the fallopian tubes as a result of previous surgery involving the fallopian tubes, endometriosis, advanced age, and smoking, which is thought to damage the epithelium lining the fallopian tubes. The individual will frequently also have a history of prior ectopic pregnancy or infertility, which may indicate some anatomical abnormality of the fallopian tubes. Okay, now after implantation, the embryo begins developing and growing just like it would in a normal pregnancy. So initial symptoms will include a missed menstrual period and other body changes like nausea and fullness of breasts, which are typically seen in early pregnancy. What we fear the most, though, is that if the ectopic pregnancy runs out of space in the fallopian tube, it may cause it to rupture. A ruptured ectopic pregnancy will present with a sudden onset of severe lower abdominal pain, which is occasionally accompanied with light vaginal bleeding. If there's massive hemorrhage into the abdominal cavity, there may also be hemodynamic instability, or even hemorrhagic shock, meaning hypotension, tachycardia, and even syncope or fainting. So, if a test question describes a female of childbearing age with sudden, severe lower abdominal pain, vaginal bleeding, and in severe cases signs of shock, as well as a history of missed menstrual periods, think of ruptured ectopic pregnancy at the top of your differentials. Diagnosis of an ectopic pregnancy can vary based on the hemodynamic status. So if the individual is hemodynamically unstable, then immediate surgery is needed to diagnose and treat the ectopic pregnancy. If they are hemodynamically stable, then serial measurements of the serum levels of HCG can be done. For your exams, it's high yield to remember that in a normal intrauterine pregnancy, the HCG levels are doubling every 48 hours. If this trend does not occur, then we can suspect an ectopic pregnancy. In addition, transvaginal ultrasound can detect the presence of an intrauterine pregnancy by week 5 or 6. It's also important to know that if uterine curettage or scraping of the uterus lining is performed, it would reveal changes in the endometrium due to progesterone secretion, but no embryonic or trophoblastic tissue. Treatment in a hemodynamically stable individual whose ectopic pregnancy is diagnosed early, meaning within the first 6 weeks of pregnancy, typically includes termination of the pregnancy with methotrexate. In contrast, in a hemodynamically unstable individual, a salpingostomy can be done. That's where the fallopian tube is opened up to remove the ectopic pregnancy and then closed at the end of surgery. Alternatively, a salpingectomy can be done, which is where the fallopian tube is completely removed. Okay, next there's placental abruption, also known as abruptio placentae. So normally, the placenta has 2 layers. There's the maternal layer, or decidua basalis, and the fetal layer, called the chorion. Placental abruption happens when there's a partial or complete separation of the uterine wall and decidua basalis. Risk factors include acute blunt trauma, like from a car crash, fall, or domestic violence. This can happen because the placenta is less elastic than the uterus, so the strong forces from traumatic events can cause the placenta to shear away from the uterine wall. Also commonly tested risk factors, which you should look for in a question stem, include smoking or chronic hypertension, which results in degeneration of the uterine arteries that supply the placenta. Remember that severe preeclampsia can also cause placental abruption. Certain illicit drugs like cocaine and methamphetamine can also cause significant vasoconstriction of the placental blood vessels and an abrupt increase in blood pressure, increasing the risk of an abruption. Other risk factors include multiparity or multiple pregnancies and a maternal age over 35 years old. Symptoms of placental abruption include an abrupt onset of abdominal pain, which usually happens in the 3rd trimester, meaning after about 20 weeks of pregnancy. Now, if the separation is near the margin of the placenta, the individual might also have continuous vaginal bleeding, and this is called an apparent abruption. But if the separation is more central, the abruption might be concealed, meaning there might be a pocket of blood that stays concealed between the decidua basalis and the uterine wall. And in this case, it's often identified later when it causes complications. So placental abruption can lead to serious blood loss from large vessels, causing life-threatening maternal and fetal complications. Maternal complications include hypovolemic shock, presenting as hypotension, tachycardia, or syncope, and Sheehan syndrome, which is a type of perinatal pituitary necrosis that results from hypovolemia. The telltale sign of Sheehan syndrome is agalactorrhea, where the individual is not able to produce enough or any breast milk due to a lack of prolactin. Another extremely popular concept among the examiners is that placental abruption is the most common cause of disseminated intravascular coagulation, or DIC. That's because the abruption causes the release of large quantities of tissue factor from the decidua basalis layer, which results in extensive clotting in blood vessels throughout the body. So what's high yield is that in terms of lab work, we'll have low platelets, decreased coagulation factors leading to prolonged PT and PTT, and elevated D-dimer levels from clot lysis. So an individual with placental abruption, increased bleeding tendency, and labs showing schistocytes, low platelets, prolonged PT and PTT, and elevated D-dimers is having DIC. On another note, fetal complications include intrauterine hypoxia and asphyxia, because the fetus is no longer receiving adequate placental perfusion. For your exams, a hint for that is fetal bradycardia, or heart rate lower than 110 beats per minute, and diminished or absent fetal movement. Diagnosis is made based on ultrasound, which can identify the position of the placenta. For treatment, if the hemorrhage is severe or if there's evidence of fetal compromise, an emergency cesarean section is needed. Next, there's vasa previa. In this case, fetal blood vessels, meaning the two umbilical arteries and umbilical vein, run over or close to the cervical os. For your exams, what's high yield is that it is commonly associated with velamentous umbilical cord insertion. Normally, the umbilical cord inserts into the middle of the placenta, but in velamentous insertion, the umbilical cord inserts in the fetal or chorioamniotic membranes and then travels within the membranes to the placenta. The result is that umbilical vessels are exposed, since they are not protected by Wharton's jelly, which is a yellow, gooey substance. And when that's combined with vasa previa, meaning that the vessels are near the cervical os, they are especially vulnerable to rupture. So upon rupture of the membranes, these vessels rupture as well, causing massive, painless bleeding. Now, depending on the extent of blood loss, complications on the maternal end can be hypovolemic shock with hypotension, tachycardia, or syncope, and Sheehan syndrome with agalactorrhea, while fetal complications can include hypoxia, manifesting as bradycardia, or even fetal death. So the classic triad for vasa previa is membrane rupture, painless vaginal bleeding, and fetal bradycardia or fetal death. Thanks to transvaginal ultrasound, diagnosis can now be made during pregnancy, before rupture of the membranes occurs. In this case, treatment consists of cesarean section. Moving on to placenta previa. Normally the placenta implants in the upper uterus, but in placenta previa, it implants in the lower uterus. The reason why this happens is unclear, but one hypothesis is that the placenta implants lower down when the endometrium in the upper uterus is not well vascularized. In fact, endometrial damage from things like a previous cesarean section, abortion, uterine surgery, multiparity, advanced maternal age, or smoking can decrease vascularization and increase the risk of placenta previa. In other cases, risk factors include having multiple placentas or a placenta with a larger than normal surface area, which can both happen with twins or triplets. Now for your exam, it's high yield to know that placenta previa is classified by how close the placenta is to the cervical os. So it can be complete, where the placenta completely covers the cervical os, partial, where the placenta partially covers the cervical os, or marginal, where the edge of the placenta extends to within 2 centimeters of the cervical os. The classic presentation of placenta previa is a sudden onset of painless, bright red bleeding that typically happens in the 3rd trimester, meaning after 20 weeks gestation. That's because as the pregnancy progresses, the lower uterine segment grows, and if the placenta is in the lower uterus, this growth disrupts the placental blood vessels, which can cause bleeding. The amount of bleeding can vary, and it can be intermittent or continuous, sometimes increasing during labor because of uterine contractions and cervical dilation. Notice, though, that unlike placental abruption, which causes painful 3rd trimester bleeding, the bleeding here is painless. Once again, based on the amount of blood loss, complications on the maternal end can be hypovolemic shock with hypotension, tachycardia, or syncope, and Sheehan syndrome with agalactorrhea, while fetal complications can include hypoxia, manifesting as bradycardia and decreased fetal movements. Diagnosis is typically made during prenatal ultrasounds, but occasionally it's not recognized until cervical changes during labor cause bleeding to happen. For treatment, if the hemorrhage is severe, or if there's evidence of fetal compromise, then an emergency cesarean section is required. Next is morbidly adherent placenta. This means that there's an abnormal attachment of the placenta to the uterine wall. Normally, the placenta reaches the decidua basalis, which is basically endometrium that has been modified to accommodate pregnancy. If the decidua is too thin, the placenta may go further and attach to the myometrium without penetrating it. That's called placenta accreta, and it's actually the most common type of morbidly adherent placenta. If it goes even deeper and penetrates the myometrium but doesn't go all the way through, it's called placenta increta. And if it invades all the way through the myometrium and into the uterine serosa, and may even extend to neighboring organs like the bladder or rectum, it's called placenta percreta. Now, the most important risk factor to remember here is prior cesarean section or uterine surgery, especially when the placenta implants itself near a scar from the previous surgery. Advanced maternal age and multiparity are also risk factors. The way morbidly adherent placenta classically presents is with difficult delivery of the placenta. You see, when the placenta is abnormally attached, it tears from the uterine wall and leaves a little bit of itself behind. And that little bit still has placental vessels, which can cause postpartum hemorrhage. While we're on the topic, it's necessary to know that there are 4 classic causes of postpartum hemorrhage, and you can remember them as the 4 T's. So first, there's uterine atony, or loss of uterine tone, which is the most common cause. Trauma, like lacerations, incisions, or uterine rupture. Thrombin, or clotting issues, such as various coagulopathies. And retained tissue, which is the case in morbidly adherent placenta. Remember that if the bleeding is severe, it can progress into hypovolemic shock with hypotension, tachycardia, or syncope, and Sheehan syndrome with agalactorrhea. Since the hemorrhage is postpartum, there are no fetal complications. Another high-yield piece of information is that for unclear reasons, placenta accreta, increta, and percreta are all associated with placenta previa. So if an exam question describes painless, bright red, 3rd trimester bleeding pointing to placenta previa, keep in mind that the individual may also experience difficulty with separation of the placenta during delivery. Diagnosis is typically made during prenatal ultrasound. Treatment depends on the severity of postpartum bleeding and can be an obstetrical emergency, so treatment begins immediately with uterine massage and uterotonic medications like oxytocin that help the uterus contract and constricts its arteries. If this doesn't work, bilateral ligation of the internal iliac artery, which supplies the uterus, can be done. If that's still unsuccessful, hysterectomy or surgical removal of the uterus is the only option. The last thing we're going to discuss is amniotic fluid abnormalities. Normally, there's a certain volume of amniotic fluid within the amniotic sac that serves as a cushion for the growing fetus. The volume of this fluid is determined by the volume of fluid flowing into and out of the amniotic sac. In the second half of the pregnancy, much of the amniotic fluid is made up of the fetus's urine with small contributions from the placenta, and then it's reabsorbed back as the fetus continually swallows it. Now, if the fetus can't properly swallow amniotic fluid, excess fluid builds up in the amniotic sac. This is known as polyhydramnios. For your exams, it's important to know that an inability to swallow, is typically a result of esophageal or duodenal atresia, but can be also due to anencephaly, where parts of the brain that's responsible for controlling swallowing are absent. Less commonly, polyhydramnios may result from increased urine production. This is the case in multiple gestation, where more fetuses produce more urine, fetal anemia, where increased cardiac output leads to increased urine production, and maternal diabetes, which causes fetal hyperglycemia and resulting polyuria. The opposite of polyhydramnios is oligohydramnios, where there's too little amniotic fluid. This is usually due to inadequate urine excretion. It can be caused by bilateral renal agenesis, where there's failure of both kidneys to develop, or posterior urethral valves in males, which block urine excretion. Placental insufficiency or insufficient blood flow to the placenta can reduce blood flow to the kidneys of the fetus and thus decrease urine production. For your exams, you definitely need to know that any cause of oligohydramnios can result in Potter sequence. That's because with less amniotic fluid, there's less space in the amniotic sac, and so the fetus is literally pressed up against the membrane of the sac. This lack of room leads to developmental abnormalities, like a flattened face, widely separated eyes with epicanthal folds, low-set ears, as well as limb abnormalities like clubbed feet. Alright, as a quick recap, gestational hypertension is hypertension that develops after 20 weeks gestation. When there's also proteinuria or other organ damage, it's preeclampsia. Preeclampsia with seizures is eclampsia. Next, gestational trophoblastic disease refers to proliferation of trophoblastic cells. It can be benign, also called hydatidiform moles, which can be complete or partial, or malignant, which include invasive moles and choriocarcinoma. Ectopic pregnancy refers to the implantation of a fertilized egg outside the uterus, and most commonly in the fallopian tubes. It should be suspected when there's a history of missed menstrual period and a slower than expected rise in HCG levels. If ruptured, it can manifest as sudden, severe lower abdominal pain, light vaginal bleeding, and in severe cases, shock. Placental abruption is the premature, partial, or complete separation of the placenta from the uterine wall, often as a result of trauma. It classically presents with abrupt, painful third trimester bleeding and can progress to DIC, maternal shock, and fetal distress. Vasa previa occurs when fetal vessels run over or is in close proximity to the cervical os. It is commonly associated with velamentous umbilical cord insertion and presents with the triad of membrane rupture, painless vaginal bleeding, and fetal bradycardia or death. Then there's placenta previa, where the attachment of the placenta is lower than normal in the uterus and manifests as painless third trimester bleeding. Morbidly adherent placenta refers to invasion of the placenta deeper than normal into the uterine wall. The specific disorder depends on the depth of invasion. Placenta accreta, which is the most common, reaches into the myometrium. Increta goes through the myometrium but doesn't penetrate the serosa. Percreta penetrates the serosa and can reach other organs. It causes difficult delivery of the placenta and postpartum hemorrhage. Finally, amniotic fluid abnormalities include polyhydramnios, which is too much amniotic fluid and usually results from inability to swallow or excess urine production, while oligohydramnios, or too little amniotic fluid, is usually caused by reduced urine excretion, like when there's bilateral renal agenesis. Okay, let's not forget about our cases. Effie came in with severe lower abdominal pain, light vaginal bleeding, a missed menstrual period, as well as hypotension and tachycardia. This is a classic presentation of ruptured ectopic pregnancy. Another clue is the history of pelvic inflammatory disease, which is a major risk factor. On the other hand, Kate presented with abrupt, painful, and continuous vaginal bleeding in her third trimester after a traumatic event. There was also signs of fetal distress, so we are suspicious of placental abruption. The fact that she's multiparous and over 35 are also risk factors for this condition. Laboratory studies also showed low platelets, prolonged PT and PTT, elevated D-dimers, and schistocytes, which point us towards DIC, a severe complication of placental abruption.
At the clinic, two mothers came in with their babies. The first baby is an 11-month-old girl called Cecile, who was brought by her parents, who are immigrants, for a routine visit. You immediately notice that she doesn't react when you call her name, as if she can't hear you at all. Upon eye examination, you find that Cecile has bilateral clouding of the lens. Then, upon cardiac auscultation, you hear a continuous rumbling murmur. Upon further questioning, Cecile's mother tells you that during the first trimester of pregnancy, she developed a rash that mainly involved her head and neck, as well as swollen lymph nodes behind the ears. After Cecile comes a 6-month-old baby boy named Arthur with his mother, who is concerned because Arthur has developed multiple purple marks on his skin. Upon physical examination, you notice that Arthur has an unusually large head for his age. Then, on fundoscopy, his eyes show white and yellow scars that look like cotton. You decide to order a CT scan of the brain, which reveals scattered calcifications. Upon further questioning, Arthur's mother admits to handling her cat's litter while she was pregnant, despite her doctor's advice against it. Alright, now both Cecile and Arthur seem to have congenital torch infection. TORCH is an acronym that stands for infections caused by Toxoplasma gondii, other agents such as syphilis, parvovirus B19, varicella zoster virus, and listeria. Then there's rubella, cytomegalovirus, and finally herpes simplex virus 2, or HSV2. All these infections are lumped together because they can be vertically transmitted, which means that a pregnant individual can transmit the infection to their child either before birth via the placenta or during and after birth via blood, body fluids, or breast milk. Now, keep in mind that torch infections may share some nonspecific signs and symptoms, including delayed growth, and hepatosplenomegaly, or enlarged liver and spleen, which can lead to jaundice or yellow skin, and thrombocytopenia or low platelet count. So for your exams, it's important that you're able to distinguish the different torch infections based on additional characteristics. Okay, the first torch infection is toxoplasmosis, which is caused by the protozoan parasite Toxoplasma gondii. For your exams, remember that pregnant individuals usually get infected from contact with cat feces, such as when handling cat litter, as well as consumption of undercooked meat, especially pork and lamb. However, keep in mind that the pregnant individual typically remains asymptomatic, or may rarely develop lymphadenopathy, or enlarged lymph nodes. The bad news is that toxoplasma can be transmitted to the fetus via the placenta, and if that happens during the first 6 months of pregnancy, it can lead to congenital toxoplasmosis. Now, the most high-yield manifestations of congenital toxoplasmosis include the classic triad of chorioretinitis, hydrocephalus, and intracranial calcifications. Chorioretinitis is an inflammation of the choroid and retina of the eye, which can be seen upon fundoscopy as white and yellow scars that look like cotton. Then, hydrocephalus is when fluid builds up within the ventricles, which are cavities within the brain. As a result, there's enlargement of the ventricles, so these babies develop macrocephaly, or an enlarged head. Finally, intracranial calcifications are basically calcifications that are typically randomly distributed within the brain tissue and can be seen on brain CT scan. An additional clue that you may find on a test question is that some babies with congenital toxoplasmosis may present with multiple purple-blue marks in the skin, which is often referred to as a blueberry muffin rash. The next torch infections are other agents, which include syphilis, parvovirus B19, varicella-zoster virus, and listeria. Now, syphilis is caused by the spirochete bacterium Treponema pallidum, which is transmitted through sexual contact, including vaginal, anal, and oral sex. Now, syphilis has 3 stages. The first stage, as soon as the person gets infected, is called primary syphilis, or early localized stage, and it's characterized by the presence of chancres, or painless skin ulcers, which usually appear on the labia, anal region, or cervix. About 2 to 10 weeks later begins the second stage, which is called secondary syphilis, or the dissemination stage, where Treponema pallidum enters the bloodstream. As a result, individuals develop generalized lymphadenopathy. In addition, individuals may present with maculopapular rash, which are small bumps that start on the trunk and spread out to the arms and legs and eventually to the palms, soles, genitalia, and other mucous membranes. And some individuals may also develop condyloma lata, which are smooth, white, painless, wart-like lesions on the genitals and around the anal region. The third stage is called latent syphilis, and that is when the disease enters a dormant or asymptomatic phase. Individuals who don't get any treatment eventually progress into the final stage of syphilis, which is called tertiary syphilis. Here, the immune cells start to huddle around and form characteristic granulomatous lesions called gummas. In addition, various organs get damaged, especially the heart and blood vessels, leading to cardiovascular syphilis, as well as the brain and spinal cord, leading to neurosyphilis. What's really important to remember is that the first and second stages are the most infectious, so that is when the fetus is most likely to get infected, either via the placenta or during childbirth. Now, congenital syphilis often results in hydrops fetalis, which is when the fetus has an abnormal accumulation of fluid in soft tissues. This poses a great risk for stillbirth, which is when the fetus dies within the womb. Babies who survive the pregnancy typically develop some characteristic features that can be divided into early signs, which appear during the first 2 years of life, and late signs, which appear after the child is 2 years old. Early signs can include a maculopapular rash involving palms and soles of feet, as well as snuffles or increased nasal secretions, which are laden with treponema. On the other hand, late signs include frontal bossing, where the forehead is really prominent, as well as a saddle nose with a depressed nasal bridge and a short maxilla. Another very characteristic finding is Hutchinson teeth, which are small, notched, and widely spaced permanent teeth. These children may also develop saber shins, which refers to bending of the shin bone or tibia. Finally, congenital syphilis may lead to progressive damage to the vestibulocochlear nerve, or cranial nerve 8, which normally transmits sound. As a result, congenital syphilis may cause deafness or hearing loss. Next up is parvovirus B19 infection, which is primarily transmitted via respiratory droplets when someone coughs or sneezes. In a pregnant individual, parvovirus B19 infection causes arthritis, or joint inflammation with pain and stiffness. This usually affects the small joints of the hands, wrists, knees, and feet, and is often symmetrical, meaning that the same joints on both sides of the body will be affected. Now, this presentation is very similar to that of rheumatoid arthritis. So, to set these two apart, remember that parvovirus B19 also leads to a decreased red blood cell production in the bone marrow, which can result in pure red blood cell aplasia. This is a type of anemia characterized by the absence of reticulocytes, which are red blood cell precursors in the bone marrow. Now, parvovirus B19 can also be transmitted by a pregnant individual to the fetus via the placenta. As a result, the fetus will also develop anemia. Because there are fewer red blood cells to carry oxygen, the heart will pump a larger volume of blood to give the growing fetus all the oxygen it needs. This raises the pressure inside the fetal blood vessels, and fluid may start to leak out. This can ultimately result in hydrops fetalis, which poses a great risk for spontaneous abortion or stillbirth, especially if the infection occurs in the first half of the pregnancy. The good news is that fetuses who survive the infection don't develop any permanent defects or malformations. Okay, moving on to the next one. Varicella, or chickenpox, is caused by the varicella zoster virus, or VZV for short. VZV can be transmitted by respiratory droplets when someone coughs or sneezes, as well as via contact with the oral or skin lesions of an infected person. What can be concerning is when the VZV infection is transmitted to a pregnant individual who is unvaccinated or has no history of previous infection. Maternal varicella zoster usually causes a fever, headache, and overall weakness. After a couple days, the pregnant individual will develop an intensely pruritic vesicular rash, which starts on the trunk and then spreads outward, eventually covering the entire body. And most importantly, the pregnant person can transmit the infection to the fetus via the placenta. The main issue is when this occurs in the first or second trimester, when the fetus is still undergoing major development and is most vulnerable. This can lead to congenital varicella syndrome, where babies are born underdeveloped, and the most high-yield findings include low birth weight, limb atrophy, and microcephaly, or an abnormally small head. In addition, these babies may develop eye defects, such as cataracts, which refer to clouding or opacification of the lens, as well as neurological defects, like cortical atrophy or brain degeneration and intellectual disability. Next up is Listeria infection, caused by the bacteria Listerio monocytogenes. In a test question, look for an individual that gets infected after ingestion of contaminated foods, like unpasteurized dairy products and deli meats. Now, in pregnant individuals, Listeria infection may cause fever, fatigue, and gastroenteritis, with diarrhea, vomiting, and abdominal cramps. Another high-yield presentation is amnionitis, or infection of the amniotic fluid, and the most severe cases may even develop sepsis, which is when Listeria spreads to the bloodstream. Now, the main route of transmission to the fetus is via the placenta, which may result in spontaneous abortion or stillbirth. If the fetus survives to term, it may develop sepsis and meningitis, which is an inflammation of the meninges that cover and protect the brain and spinal cord, and is fatal if untreated. The next letter in TORCH is R, which stands for rubella infection, previously known as German measles. This is caused by rubella virus, which can be transmitted to a pregnant person via respiratory droplets. A very important fact that you must remember is that most children from 12 to 15 months of age get the MMR vaccine against measles, mumps, and rubella. So, in a test question, you should be suspicious of rubella infection in an individual that may not be vaccinated, such as an immigrant. Now, the maternal infection manifests with a maculopapular rash that starts from the head and neck and spreads downward, as well as postauricular lymphadenopathy, which is an enlargement of the lymph nodes behind the ears. Another high-yield manifestation of maternal rubella infection is polyarthritis, so arthritis that involves at least 5 joints. And if the infection occurs during the first trimester of pregnancy, the fetus may develop congenital rubella syndrome. For your exams, you have to know the characteristic triad of congenital rubella syndrome, which includes deafness, cataracts, and congenital heart defects like patent ductus arteriosus. Now, an important clue for patent ductus arteriosus may be heard upon cardiac auscultation as a continuous rumbling murmur, which is often referred to as a machinery murmur. In addition, keep in mind that some newborns may also present with a blueberry muffin rash. Next up in TORCH, we have cytomegalovirus, or CMV infection, which is mainly transmitted through sexual contact, but can also be transmitted via organ transplantation. Now, pregnant people who get infected by CMV are usually asymptomatic, but some can develop mononucleosis-like symptoms. These typically include fever, lymphadenopathy, and a sore throat. Now, CMV infection can be passed to the fetus via the placenta. Babies born with congenital CMV infection can present with petechiae, which are tiny purple, red, or brown spots on the skin, as well as a blueberry muffin rash. Other hallmark features of congenital CMV include progressive and permanent deafness, as well as eye abnormalities, such as chorioretinitis, or an inflammation of the choroid and retina. Now, congenital CMV can also affect the brain, causing seizures and intellectual disability, which are often associated with microcephaly. And a high-yield finding that can be seen on brain CT scan are periventricular calcifications, which are calcifications around the ventricles of the brain. Finally, there's herpes simplex virus 2, or HSV2, infection, which is transmitted through direct contact with infected areas of the skin or mucous membranes. Now, HSV2 infection in a pregnant individual is usually asymptomatic, but it can develop genital herpes, which is characterized by vesicular skin lesions that form on the vaginal mucosa, mons pubis, cervix, and labia. Now, HSV2 infection can also be passed from a mother to a baby, but this mainly happens during childbirth, when the baby passes through infected vaginal secretions. Neonatal HSV2 infection also presents with the characteristic vesicular skin lesions, which mainly involve the scalp, the eyelid margins, and the oral mucosa. But what's really high yield is that HSV2 infection in neonates can lead to meningoencephalitis, or inflammation of the meninges in the brain. This can present with lethargy, irritability, and even seizures. Alright, as a quick recap. Congenital torch infections are vertically transmitted infections caused by Toxoplasma gondii, other agents such as syphilis, parvovirus B19, varicella zoster virus, listeria, rubella, cytomegalovirus, and herpes simplex virus 2. Toxoplasma is transmitted via contact with cat feces or consumption of undercooked meat, and a pregnant individual can then transmit it to the fetus via the placenta. If that happens during the first 6 months of pregnancy, it can lead to congenital toxoplasmosis with the triad of chorioretinitis, hydrocephalus, and intracranial calcifications. Syphilis is usually transmitted to the pregnant person via sexual contact, while the fetus can get infected either through the placenta or during childbirth. Congenital syphilis often results in hydrops fetalis and poses a great risk for stillbirth. Babies who survive typically present with frontal bossing, a saddle nose, short maxilla, Hutchinson teeth, saber shins, and may develop deafness. Parvovirus B19 infection is primarily transmitted via respiratory droplets when someone coughs or sneezes. It can present in the pregnant individual with arthritis and pure red blood cell aplasia, while the fetus can develop anemia and hydrops fetalis, which poses a great risk for spontaneous abortion or stillbirth. Varicella zoster virus infection can occur in unvaccinated people without a history of previous infection. A pregnant person can then transmit it to the fetus via the placenta. Now, if the infection occurs in the first or second trimester of pregnancy, the fetus can develop congenital varicella syndrome, which is characterized by low birth weight, limb atrophy, and microcephaly, as well as eye and neurological defects. Listeria infection occurs after consumption of unpasteurized dairy products and deli meats, and is mainly transmitted to the fetus via the placenta, which can result in spontaneous abortion or stillbirth. If the fetus survives to term, it may develop sepsis and meningitis. Rubella infection can be transmitted via respiratory droplets to a pregnant person who did not get the MMR vaccine, and it can pass onto the fetus, especially during the first trimester, causing the triad of deafness, cataracts, and congenital heart defects. Cytomegalovirus can be transmitted via sexual contact or organ transplantation to the pregnant person, who can in turn pass it to the fetus via the placenta. Congenital cytomegalovirus is characterized by petechiae, deafness, and chorioretinitis, as well as periventricular calcifications and seizures. Finally, herpes simplex virus 2 infection is transmitted through direct contact with infected areas of the skin, or mucous membranes, so it can be transmitted during childbirth to the baby. These babies can develop vesicular skin lesions and meningoencephalitis. Alright, finally going back to our cases. Cecile is the 11-month-old baby girl that presents with deafness and cataracts. These two symptoms alone are present in various congenital torch infections, but combined should already make you think of rubella. Upon cardiac auscultation, Cecile has a machinery murmur, which indicates that she has a congenital heart defect. This completes the characteristic triad of congenital rubella syndrome. An additional clue is that Cecile's mother developed, when pregnant, a rash that mainly involved her head and neck, combined with post-auricular lymphadenopathy, which are typical of maternal rubella infection. And because Cecile's parents are immigrants, her mother might not have gotten the MMR vaccine. On the other hand, Arthur is the 6-month-old baby boy who developed a blueberry muffin rash. Now, a very suggestive clue here is the fact that Arthur's mother handled her cat's litter while she was pregnant, which should immediately make you think of toxoplasmosis. The key here is that Arthur has a unique combination of chorioretinitis and intracranial calcifications, which are 2 out of 3 manifestations of the classic triad of congenital toxoplasmosis. And remember that the third manifestation is hydrocephalus, which is probably what caused Arthur's macrocephaly.
Clay, a 17-year-old male, arrives at the clinic after noticing that he's not developing like his friends. On further questioning, Clay mentions that he was born without a sense of smell. Upon physical examination, you notice that he has no facial or body hair, and that his external genitals are small and underdeveloped for his age. You decide to run a blood test, which shows low levels of the hormones GnRH, LH, FSH, and testosterone. Finally, you order a semen analysis, which reveals a low sperm count. Next comes Jessie, a 13-year-old girl, and her concerned mother, who's noticed that Jessie has started to develop some masculine features, such as a deeper voice and excess body hair growth. A blood test shows increased testosterone levels and low dihydrotestosterone, so you decide to perform a karyotype test, which reveals 46 chromosomes, with one X and one Y chromosome. Okay, now, based on their initial presentation, both Clay and Jessie seem to have some form of disorder of sexual development and sex hormones. But first, let's go over some terminology. On the one hand, we all have a genotypic sex, which is determined by our karyotype, or set of chromosomes. Generally, there are 2 sex chromosomes. Those who have X and Y sex chromosomes are typically considered genetically males, while those who only have X chromosomes are typically considered genetically females. On the other hand, phenotypic sex is determined by the primary sexual characteristics, so the genitalia and gonads, as well as the secondary sexual characteristics, such as breast and muscle development, as well as body hair and fat distribution. The development of primary and secondary sexual characteristics is generally under control of the hypothalamic pituitary gonadal axis. First, the hypothalamus secretes gonadotropin-releasing hormone, or GnRH for short, which goes to the anterior pituitary to stimulate the release of gonadotropic hormones, which are luteinizing hormone, or LH, and follicle-stimulating hormone, or FSH. LH and FSH then stimulate the gonads to produce sex hormones. In males, LH stimulates the Leydig cells of the testes to secrete testosterone, and FSH stimulates the Sertoli cells to secrete inhibin B. Testosterone and inhibin B are responsible for the development of male primary sexual characteristics, like enlargement of the penis and testes, as well as male secondary sexual characteristics, such as a deepening of the voice, a male pattern of hair growth on the face, chest, axilla, and genital areas, and increased muscle mass. On the other hand, in females, LH and FSH stimulate the ovaries to secrete estrogen and progesterone, which are responsible for the female primary sexual characteristics, like ovulation, menstruation, and uterine development, as well as female secondary sex characteristics, like breast development, hip widening, and hair growth, mainly on the axilla and genital areas. Now, once sex hormones have done their job, they signal the hypothalamus and pituitary via negative feedback to turn off the secretion of GnRH, LH, and FSH. Now, disorders of sexual development, or DSD for short, are characterized by a discrepancy between an individual's genotypic and phenotypic sex. Let's say there's an individual that has a 46XY karyotype, so they're genetically male and they have testes, but their external genitalia show a feminine or ambiguous appearance. So this is called a 46XY DSD. The opposite scenario would be an individual with a 46XX karyotype, so they're genetically female and have ovaries, but present with virilized or ambiguous external genitalia. And this is called a 46XX DSD. The previous terminology for DSDs includes terms like hermaphrodite or pseudo-hermaphrodite. However, these terms can be considered derogatory, so they're no longer in common use. And although currently the most widely used term is disorders of sexual development, keep in mind that it's also falling out of favor, since it's considered overbroad, and the word disorder may have a negative connotation. So don't be surprised if there's a new term in the future. For your exams, some high-yield disorders of sexual development and sex hormones include ovotesticular disorder, androgen insensitivity syndrome, 5-alpha reductase deficiency, placental aromatase deficiency, Kallmann syndrome, precocious puberty, and androgenic steroid abuse. Let's start with ovotesticular disorder. Now, the cause of this disorder isn't totally clear. What's important for your exams is that most individuals with ovotesticular disorder have a 46XX karyotype, so they're genetically female. But keep in mind that it can also affect individuals that are 46XY, as well as those who have a mosaic karyotype, where some cells are 46XX, while others are 46XY. Now, as the name suggests, individuals with ovotesticular disorder have a mixed phenotypic sex. Most affected individuals present with ovotestis, which is a gonad made up of a combination of ovarian and testicular tissue. On the other hand, some affected individuals may develop an ovary on one side and testis on the other. In addition, individuals with ovotesticular disorder usually have ambiguous genitalia, meaning that the appearance of their external genitalia isn't clearly male or female. Previously, ovotesticular disorder was called true hermaphroditism, after the Greek god Hermaphroditus, who was united with the nymph who fell in love with him into a single body with both masculine and feminine characteristics. Nowadays, this term is no longer used. Next, we have androgen insensitivity syndrome, which is the most common form of 46XY DSD. This is caused by a mutation in the androgen receptor gene, which is found on the X chromosome. Androgen insensitivity syndrome is an X-linked recessive disorder, so it typically affects genetic males because they only have one X chromosome. On the other hand, genetic females generally have two X chromosomes, so even if they have a defective gene on one chromosome, they still have another functional one. Okay, normally during the first trimester of fetal life, the gonadal sex develops either into testes or ovaries. In males, a gene on the Y chromosome, called the sex-determining region Y, or SRY gene, helps the fetal gonads turn into testes, which are initially located in the abdomen. In turn, the testes start producing androgens, the main one being testosterone. A small fraction of testosterone gets converted by the enzyme 5-alpha reductase into its more potent form called dihydrotestosterone, or DHT, which is mostly responsible for development of male external genitalia. And that's a high-yield fact. Internally, there's a set of ducts called Wolffian and Mullerian ducts. Testosterone also causes the Wolffian ducts to differentiate into the male reproductive system. At the same time, the testes also produce a hormone called anti-Mullerian hormone, which prevents the Mullerian ducts from developing into the female reproductive system, and instead makes them degenerate. During the third trimester, testosterone helps the testes descend from the abdomen into the scrotum. On the other hand, in females, there's no Y chromosome, so the SRY gene is absent. As a result, ovaries develop from the internal gonads, and androgen levels remain relatively low, so they develop female external genitalia. Now, individuals with androgen insensitivity syndrome have normal functioning testes that produce androgens. But these hormones can't exert their action because there's a defect in the androgen receptor. Without the effects of androgens, the testes sometimes don't descend into the scrotum, and instead remain in the abdomen or pelvis, which is called cryptorchidism. What's important for your exams is that cryptorchidism is related to a higher chance of developing testicular cancer later in life. Additionally, with androgen insensitivity syndrome, the genitals develop an overall feminine appearance, with a rudimentary vaginal opening, and a normal-looking clitoris and labia. Even though androgen influence is missing, the testes still produce anti-Mullerian hormone, which means that these individuals don't have a uterus and fallopian tubes, and thus their vagina ends in blind pouch. During puberty, some of the excess androgens may end up being converted to estrogen by the enzyme aromatase. As a result, affected individuals may develop female secondary sex characteristics, such as widening of the hips, gynecomastia or breast growth, and scant pubic and axillary hair. Androgen insensitivity syndrome can sometimes remain undiagnosed until puberty, when an individual that has female genitalia doesn't start menstruation. And on a blood test, individuals with androgen insensitivity syndrome may have increased levels of testosterone, estrogen, and LH. Finally, a karyotype test can be done to confirm the genotypic sex. Treatment typically involves surgical removal of the testes, especially in the case of cryptorchidism, to reduce the risk for cancer. In addition, individuals who choose to adopt a female gender identity can use estrogen supplements, while those who adopt a male gender identity can use testosterone or DHT supplements. Another high-yield 46XY DSD fact is 5-alpha reductase deficiency, which is caused by a mutation in the SRD5A2 gene. What you need to know is that this gene codes for the enzyme 5-alpha reductase, which normally converts testosterone to DHT. For your exams, remember that 5-alpha reductase deficiency is inherited in an autosomal recessive but sex-limited pattern. This means that for the disease to appear, both copies of the gene have to be mutated, and the individual has to be genetically male, since dihydrotestosterone has no role in female sexual development. And that's very high yield. With 5-alpha reductase deficiency, the problem arises in a male fetus where the testes produce testosterone, but isn't converted into DHT. As a result, they develop male internal sex organs, but the external genitalia appear ambiguous or female. In particular, the penis doesn't fully elongate, and the scrotum often remains split in two, which is also called a bifid scrotum. When these individuals reach puberty, there's a huge testosterone surge. So even though it can't be converted to DHT, there's so much testosterone around that the penis and scrotum grow larger and start acquiring a masculine appearance. In addition, individuals start developing a deeper voice, muscle growth, and facial and body hair growth. Diagnosis of 5-alpha reductase deficiency is usually suspected in newborns with ambiguous genitalia, and a karyotype can be performed to confirm the genotypic sex. What's high yield is that blood tests usually show normal serum testosterone and estrogen levels, low DHT levels, and normal or increased LH levels. Treatment of 5-alpha reductase deficiency is focused on hormone replacement therapy. Moving on, placental aromatase deficiency is a 46XX DSD caused by a mutation in the CYP19A1 gene, which codes for the enzyme aromatase that normally converts androgens to estrogens. Now, placental aromatase deficiency is also inherited by an autosomal recessive but sex-limited pattern. But unlike 5-alpha reductase deficiency, this mainly affects genetically female individuals, since estrogens are the main female sex hormones. And that's very high yield. Now, during gestation of a baby affected with placental aromatase deficiency, the abnormally high androgen levels from the fetus can cross the placenta into the mother's bloodstream. As a result, there's maternal virilization, which is characterized by deepening of the voice, hirsutism or excessive body hair growth, and acne or multiple skin pimples mainly involving the face. Keep in mind that maternal virilization usually regresses after giving birth when the fetal androgens aren't around anymore. Now, infants with placental aromatase deficiency have ovaries internally, but their external genitalia look ambiguous or masculine. At puberty, they develop progressive virilization, associated with a lack of breast development and amenorrhea, or absence of menstruation, which leads to infertility. In addition, these individuals may often develop multiple ovarian cysts, which are fluid-filled sacs in an ovary. Blood tests in placental aromatase deficiency show very low serum estrogen levels, as well as increased serum testosterone and androstenedione, which is an androgen precursor. Treatment can involve hormone replacement therapy with estrogen. Switching gears, Kallmann syndrome is a genetic disorder of sexual development with unclear inheritance patterns that can affect either genetically male or female individuals. Normally, during fetal development, there's a region of the brain called the olfactory placode, from which two groups of neurons emerge. The first group contains olfactory neurons, which migrate down from the olfactory placode and get embedded in the cribriform plate. This bone plate separates the nasal cavity from the brain and serves as a base supporting the olfactory neurons, which form the olfactory bulb that senses smells. The second group contains GnRH neurons that release gonadotropin-releasing hormone, or GnRH. These neurons migrate through the cribriform plate and settle into the hypothalamus. In Kallmann syndrome, there's a defect in the migration of the olfactory placode neurons. That includes the olfactory neurons, leading to hyposmia, which is the reduced sense of smell, or even anosmia, which is the complete loss of smell. It also includes the GnRH neurons, which results in a decreased GnRH secretion by the hypothalamus. As a consequence, the pituitary is not stimulated, so there's low levels of the gonadotropins LH and FSH. This ultimately results in hypogonadotropic hypogonadism, meaning that there's decreased gonadal function due to a lack of stimulation from the hypothalamus or pituitary. And that's a high-yield fact. In males, this leads to a decrease in testosterone, while in females there's a decrease in estrogen and progesterone. This disruption in hormones prevents puberty from beginning or successfully completing, leading to underdevelopment of primary and secondary sex characteristics. In males, primary sex characteristic dysfunction includes having a small penis and testes, as well as a low sperm count. On the other hand, secondary sex characteristic dysfunction includes a lack of facial hair, low muscle mass, and not developing a deep voice. In females, the most important primary sex characteristic dysfunction is amenorrhea, while secondary sex characteristic dysfunction includes a lack of breast development and pubic hair. In addition, what's high yield is that in both sexes, Kallmann syndrome often leads to infertility. Diagnosis of Kallmann syndrome involves blood tests revealing low levels of GnRH, LH, FSH, and sex hormones. What's important to note is that the levels of other pituitary hormones remain normal. Treatment is mainly focused on hormone replacement therapy to help stimulate puberty and the development of secondary sex characteristics. On the flip side, there's precocious puberty, which is characterized by the development of secondary sexual characteristics at an earlier age than the average. Generally, puberty is considered precocious if it begins before the age of 8 in females and the age of 9 in males. And that's something you must absolutely remember. Now, precocious puberty can be classified in two types, central or peripheral. Central precocious puberty results from early maturation of the hypothalamic pituitary gonadal axis. When that happens, there's an increased secretion of GnRH, which ultimately causes an increase in sex hormones. Most of the time, central precocious puberty is idiopathic, meaning there's no clear cause. Less frequently, central precocious puberty may result from a hypothalamic tumor that's releasing GnRH. On the other hand, peripheral precocious puberty is the result of an abnormal overproduction of sex hormones by the testes or ovaries. But unlike central precocious puberty, it's GnRH independent, and that's very high yield. Now, peripheral precocious puberty could be caused by an ovarian or testicular cyst or tumor that's oversecreting sex hormones. Peripheral precocious puberty can also be caused by genetic conditions like congenital adrenal hyperplasia, which is an overgrowth of the adrenal glands that ultimately causes them to produce more androgens, as well as McCune-Albright syndrome, which is characterized by a hyperfunctioning endocrine system. Finally, keep in mind that peripheral precocious puberty can be the result of exposure to exogenous sex hormones from medications or creams. Now, the key feature of precocious puberty is early development of secondary sexual characteristics. In males, this typically includes premature adrenarche, which refers to the development of typical masculine hair growth, body odor, and acne. On the other hand, females may experience premature thelarche, or breast development, as well as premature menarche, which is the first menstrual period. In addition, both sexes may present with acceleration of linear growth, meaning that they typically have an early growth spurt. Also, precocious puberty is associated with early somatic or physical maturation, as well as skeletal or bone maturation, so these children may be taller than their peers. However, the epiphyseal plates of the long bones tend to close prematurely too, ultimately resulting in short adult height. Precocious puberty is diagnosed using the Tanner scale, which is a predictable set of steps that males and females go through as they develop primary and secondary sex characteristics and become sexually mature. Treatment of central precocious puberty can involve GnRH agonist medications to block pubertal development, while treatment of peripheral precocious puberty depends on the underlying cause. Last but not least, There's androgenic steroid abuse, which causes an acquired disorder of sexual development. Androgenic steroid abuse refers to the misuse of anabolic androgenic steroids, which are synthetic substances that can activate androgen receptors and can be taken orally, applied topically, or can be injected either intramuscularly or subcutaneously. Anabolic androgenic steroids tend to increase muscle size and strength and promote erythropoiesis, meaning they increase red blood cell production. As a result, some individuals use androgenic steroids illegally to improve their athletic performance. However, when androgenic steroids are misused, they can lead to many undesired effects. In females, androgenic steroids can cause virilization, which includes hirsutism, and male pattern baldness, which involves the crown of the scalp. In addition, some females may experience menstrual irregularity, breast atrophy, and may develop acne. On the other hand, in males, excessive androgen levels can inhibit the hypothalamic pituitary gonadal axis via a negative feedback mechanism. This ultimately leads to a decrease in intratesticular testosterone, and thus gonadal atrophy, which is characterized by testicular shrinking and low sperm count or even azoospermia, which is a complete absence of sperm in the semen. In addition, some of the excess androgens may be converted into estrogen by the enzyme aromatase, leading to gynecomastia and acne. Finally, some individuals may experience behavioral changes, such as aggressiveness or mood swings. For diagnosis of androgenic steroid abuse, blood tests show high hemoglobin and hematocrit levels due to the increased erythropoiesis. In addition, individuals would have increased levels of exogenous testosterone, along with decreased levels of LH and FSH. All right, as a quick recap, disorders of sexual development are characterized by a discrepancy between the phenotypic sex and the gonadal sex. Ovotesticular disorder is a condition that mostly affects individuals with a 46XX karyotype, who develop ovotestes and ambiguous genitalia. Androgen insensitivity syndrome is an X-linked recessive condition caused by a loss of function of the androgen receptor and affects XY individuals, who develop testes that sometimes don't descend into the scrotum, which is called cryptorchidism, and their external genitals present a feminine appearance. 5-alpha reductase deficiency is an autosomal recessive disorder affecting 46XY individuals and results in a male fetus being unable to convert testosterone into DHT. This leads to male internal organs and ambiguous external genitalia. But when these individuals reach puberty, there's a huge increase in testosterone that causes masculinization. Placental aromatase deficiency mainly affects 46XX individuals that have a mutation in the enzyme aromatase, resulting in very low estrogen levels, as well as increased testosterone and androstenedione, which cause masculinization. During gestation of a baby with placental aromatase deficiency, the fetal androgens may cause maternal virilization. Kallmann syndrome is characterized by decreased or complete loss of smell, as well as hypogonadotropic hypogonadism, with decreased levels of GnRH, FSH, LH, and sex hormones, leading to low sperm count in males and amenorrhea in females. Precocious puberty indicates an early development of secondary sexual characteristics, typically before the age of 8 in females and before the age of 9 in males. Central precocious puberty is characterized by increased GnRH secretion, while peripheral precocious puberty is characterized by a GnRH-independent increase in sex hormones, which may be caused by an ovarian or testicular tumor, genetic conditions, or exposure to exogenous sex hormones. Lastly, Androgenic steroid abuse is caused by misuse of anabolic androgenic steroids, which results in increased muscle size and strength, and high hemoglobin and hematocrit levels, as well as virilization in females and acquired sexual development problems such as gynecomastia, testicular shrinking, and low sperm count. Clay is a 17-year-old male who's experiencing delayed sexual development. He hasn't grown any facial or body hair, and his external genitals are small and underdeveloped for his age. This should already make you think of delayed puberty. In addition, Clay's low sperm count, together with the decreased levels of GnRH, LH, FSH, and testosterone, all point to hypogonadotropic hypogonadism. The final clue is the fact that Clay was born without a sense of smell, which is very characteristic for Kallmann syndrome. Next, there's Jessie, a 13-year-old girl who's experiencing masculinization, with changes like a deeper voice and increased body hair. This indicates that Jessie has a disorder of sexual development, which, according to her karyotype test results, is a 46XY DSD. This means that Jessie is in fact genetically male. An important clue for diagnosis is that Jessie's blood testosterone levels are high, which is causing masculinization now that Jessie has reached puberty. But the key here is that the DHT levels are low, which is typical of 5-alpha reductase deficiency.
Two people came to the infectious disease clinic. The first one's David, a 42-year-old man who has a fever associated with a cough and difficulty breathing. David mentions that he's HIV positive, so you decide to run a blood test, which reveals an alarming T-cell count of 180 cells per cubic millimeter. You immediately ask for a chest X-ray, which shows gray, hazy-looking areas in both lungs. Next comes Charles, a 32-year-old man. Charles was referred to the clinic by his dentist, who detected white plaques on both sides of his tongue. When you try to scrape the plaques with a tongue depressor, you realize that they can't be removed. Upon further questioning, Charles tells you that lately he's been losing a ton of weight, although he hasn't been exercising or dieting at all. You decide to ask for an HIV-1, HIV-2 antigen antibody immunoassay, which turns out positive. Okay. Now both David and Charles have HIV, which stands for Human Immunodeficiency Virus. HIV specifically targets the cells of our immune system, leading to progressive immunodeficiency, which is when the immune system begins to fail gradually. Ultimately, affected individuals can develop AIDS, or acquired immunodeficiency syndrome. What's important to note is that AIDS puts an increased risk of certain opportunistic infections or tumors that a healthy immune system would usually be able to fend off. Now, HIV can be transmitted via certain bodily fluids from an infected person, including blood, genital fluids like semen or vaginal discharge, and breast milk. However, HIV is not present in saliva, sweat, urine, or feces. Now, to contract the infection, these bodily fluids need to come into direct contact with the healthy person's blood, broken skin, or mucosal surfaces. The most common means of transmission is horizontal via sexual intercourse, especially via male-to-male transmission, but also male-to-female and female-to-male transmissions can occur, while female-to-female transmission of HIV is quite rare. The next most common means of horizontal transmission involves direct blood-to-blood contact, which, remember, is most common among intravenous drug abusers who share needles. Less commonly, blood-to-blood contact can occur via accidental needle stick injuries, or by transfusing blood products from an infected donor. To prevent this, blood donations are always screened for infections like HIV, among others. Finally, for your exams, you must absolutely know that HIV can also be passed via vertical transmission, which means that a pregnant individual can transmit the infection to their child before birth via the placenta, as well as during delivery via blood or genital fluids, and afterwards via breast milk, and that's very high yield. Alright, now there are two distinct types of HIV, HIV-1 and HIV-2. Although they're basically the same, keep in mind that HIV-1 is more common, while HIV-2 is less infectious and thus less common. Now, regardless of the type, the viral structure is the same. HIV is a single-stranded, positive-sense, enveloped RNA retrovirus. HIV has a diploid genome, which means the virus has two copies of positive-sense single-stranded RNA. Within this RNA, there's the genes that contain all the necessary information to synthesize the viral enzymes and structural proteins within the infected cells. For your exams, there are three main genes you need to remember. The first one's the GAG gene, which codes for two important structural proteins. One is the capsid protein P24, and the other one is the matrix protein P17. Then there's the POL gene, which codes for enzymes like reverse transcriptase, integrase, and protease, which we'll cover in a bit. Finally, the NV gene codes for glycoprotein GP160, which is then cleaved by the protease to form two envelope glycoproteins, GP120 and GP41. Now, once HIV enters the bloodstream, it targets CD4 plus cells, which are immune cells that have this specific protein called CD4 on their membrane. For your exams, the main CD4 cells to remember are T helper cells and macrophages. Normally, the CD4 protein helps these cells communicate with other immune cells in order to trigger an immune response against foreign pathogens. So this little protein is pretty important for our immune system, but it's also HIV's main receptor. In fact, HIV attaches to the CD4 protein via the glycoprotein GP120, found on its envelope. But remember that this is not enough to get inside the cell. GP120 also needs to bind to a co-receptor. During early infection, the most common co-receptor that HIV uses is the membrane protein CCR5, which is typically found on T cells and macrophages. On the other hand, during late infection, HIV tends to switch to the membrane protein CXCR4, which is mainly found on T cells. Now, for your exams, you must absolutely know that some people have a mutated CCR5 gene. Heterozygous mutations typically result in the expression of fewer CCR5 proteins on the host cells, which makes it harder for the virus to infect them. As a result, these individuals present with a slower disease progression. On the other hand, individuals with homozygous mutations don't express any CCR5. As a result, HIV can't infect their cells, so these individuals are resistant or immune to HIV. Unfortunately, CCR5 mutations aren't that frequent. Now for those without this mutation. Once GP120 binds to CD4 and either CCR5 or CXCR4, the glycoprotein GP41 is exposed and anchors to the cell membrane. This allows the viral envelope to fuse with the cell membrane, and the virus is able to inject its RNA and enzymes into the cell. Once inside the cell, the enzyme reverse transcriptase uses this viral RNA to synthesize a complementary double-stranded piece of proviral DNA. Then, this proviral DNA enters the host cell's nucleus, where the enzyme integrase helps it integrate into the host cell's DNA. As a result, whenever the host cell transcribes and translates its own DNA into RNA proteins, it will end up inadvertently transcribing and translating HIV's RNA and proteins too. Pretty sneaky, huh? Ultimately, new HIV viruses are assembled and bud off from the cell membrane to infect more cells. One important thing to be aware of is that HIV tends to make tons of errors when it replicates. As a result, the virus can rapidly acquire mutations that create various HIV strands, which contain slightly different viral enzymes and structural proteins. Now, the reason why this is so important is that it allows the virus to evade the host's immune response, as well as develop resistance to treatment, and that's a high-yield fact. Okay, Now, if HIV infection is left untreated, it will progress over time, resulting in 4 clinical stages. The first one is the acute stage, which starts as soon as the individual gets infected. Most often, this initial or primary infection is mediated by the R5 strain of HIV, which uses the CCR5 co-receptor to infect macrophages and T cells near the infection site. What's important to note here is that during this initial period, the individual is already infectious, but the virus hasn't replicated enough to be detectable via HIV tests. So, during this initial period of time called the window period, individuals who get tested can get a false negative result. For your exams, remember that the window period for HIV usually lasts about 1 month, but it can range between 10 days to 3 months. Now, during this window period, infected cells start migrating from the infection site to the lymph nodes, where a lot of immune cells live. This leads to a big spike in HIV replication, while the T cells decline dramatically. At a certain point, the virus replicates so much that the window period ends and the HIV tests are able to detect the infection. Now, HIV replication continues to increase until it peaks at about week 6 from the primary infection. At this point, individuals may begin to experience flu-like or mononucleosis-like symptoms, such as fever, fatigue, lymphadenopathy, or swollen lymph nodes, and joint or muscle aches. These symptoms typically last for about 2 weeks, during which the immune system mounts a counterattack and starts to control the amount of viral replication. As a result, the viral count declines while the T cells rise again. This trend usually continues until month 2. During this period, the T cell count usually remains at a normal level, over 500 cells per cubic millimeter. As the virus declines, the HIV infection enters its second stage, which is the chronic or clinically latent stage, and this stage can last anywhere between 2 to 10 years. Now, during this stage, the T cell count usually remains at a level that's between 350 and 500 cells per cubic millimeter. So the affected individual can still fight off other infections and initially remain asymptomatic. However, bear in mind that the virus keeps slowly replicating in the lymph nodes, while T cells gradually decrease. As a consequence, the immune system progressively weakens, and some latent or dormant infections can reactivate. A very common one is herpes simplex virus, which causes herpes, with painful oral blisters or genital ulcers and pustules, as well as varicella zoster virus, which may lead to shingles, with painful vesicles that are typically located along one dermatome. Another very high-yield latent pathogen is Mycobacterium tuberculosis, which causes a pulmonary disease called tuberculosis. In addition, people living with HIV are more susceptible to develop community-acquired pneumonia. And for your exams, remember that the most common cause is Streptococcus pneumoniae. Now, remember how HIV replication can create viral mutations? Well, during the clinically latent stage, some individuals may develop an X4 strain of HIV that targets the CXCR4 co-receptor, which is essentially only on T cells. These X4 strains kind of lay low in the lymphoid tissues and steadily destroy CD4+ T cells as the viral count increases. That leads to the third stage of HIV infection, or the symptomatic stage. At this point, the body's T cells drop low enough, between about 200 and 350 cells per cubic millimeter. As a consequence, individuals become moderately immunocompromised and may start developing relatively minor infections. Among the most frequent ones, there's oral thrush, also known as oral candidiasis, which is a scrapable white plaque caused by the yeast Candida albicans. The diagnosis can be confirmed upon pseudohyphae. This is when Candida cells have an elongated shape that looks like long, thin filaments. Another similar lesion is oral hairy leukoplegia, which is a hairy-looking white plaque on the side of the tongue caused by Epstein-Barr virus. To set these two white plaques apart, the main difference is that hairy leukoplegia is unscrapable, and that's a high-yield fact. Another characteristic condition at this stage is Kaposi sarcoma, which is a malignant tumor of the skin and soft tissues that's caused by the human herpes virus 8, or HHV8. What's important to note is that upon a punch biopsy, you'll find lymphocytic inflammation, meaning that the skin is infiltrated with lymphocytes. Finally, individuals at the symptomatic stage often develop malignant lesions from infection by the human papillomavirus, or HPV. These include squamous cell carcinoma of the anus in males and cervix in females. As the viral count continues to increase, more T cells are lost. Ultimately, individuals reach the fourth stage of HIV infection, called AIDS, which is when the T cells fall below 200 cells per cubic millimeter. At this point, individuals become severely immunocompromised and may present with persistent fever, fatigue, unintentional weight loss, and diarrhea. In addition, having a T cell count below 200 cells per cubic millimeter puts the affected individual at risk for some serious AIDS-defining conditions, such as certain tumors or opportunistic infections that a healthy immune system would typically be able to fend off. Ultimately, many people with HIV infection die from these conditions. A very high-yield AIDS-defining condition is histoplasmosis, which is caused by the fungus Histoplasma capsulatum. Most individuals with histoplasmosis experience fever, weight loss, and fatigue, as well as cough and dyspnea. In addition, some individuals may present with diarrhea, nausea, and vomiting. For diagnosis, the most high-yield features seen with a peripheral blood smear are oval yeast cells with macrophages. Another AIDS-defining condition is pneumocystis pneumonia by the fungus Pneumocystis jirovecii. This condition also presents fever, weight loss, and fatigue, as well as cough and dyspnea. So to differentiate it from histoplasmosis, a key finding on chest imaging that should make you think of pneumocystis are ground glass opacities, which are gray, hazy-looking areas in the lungs. So be sure to keep an eye out for this clue. Another very frequently tested age-defining condition is progressive multifocal leukoencephalopathy, which is caused by the JC virus. Keep in mind that JC virus can be found latent in most people, since a healthy immune system can keep it under control, but it can reactivate in cases of severe immunosuppression. Now, progressive multifocal leukoencephalopathy is a demyelinating disease that affects multiple locations of the brain and worsens over time. Symptoms typically include progressive motor and cognitive neurological symptoms like weakness, clumsiness due to lack of coordination, speech difficulties, and dementia. Diagnosis of progressive multifocal leukoencephalopathy can be confirmed via MRI, where the demyelination can be spotted as non-enhancing areas. Finally, a very important AIDS-defining condition is HIV-associated dementia, which occurs when the virus spreads to the brain. These individuals present with an altered mental status as well as cerebral atrophy, which can be seen on neuroimaging. But there's more. Over time, as the T cell count falls below 100 cells per cubic millimeter, individuals become severely susceptible to opportunistic infections. One of them is aspergillosis, a lung infection that's caused by the fungus Aspergillus fumigatus. Symptoms include hemoptysis, or coughing up blood, and phleuritic chest pain, as well as fever, cough, and dyspnea. A very high-yield fact for diagnosis is that chest imaging can reveal pulmonary infiltrates and cavitation due to tissue necrosis. Another big one is cryptococcosis. This is caused by inhaling the fungus Cryptococcus neoformans, which is typically found in soil and bird droppings. Rarely, the infection can affect the lungs, which is known as pulmonary cryptococcosis. However, in severely immunocompromised individuals, the infection may disseminate or spread to the brain, causing cryptococcal meningitis. Affected individuals may experience symptoms like headache and sensitivity to light, as well as nausea and vomiting. If cryptococcal meningitis is suspected, diagnosis can be confirmed using an India ink stain of the cerebrospinal fluid. And because Cryptococcus neoformans is an encapsulated yeast, this stain allows to see a clear halo around the yeast cells. In addition, a latex agglutination test can be used to detect the characteristic polysaccharide capsular antigens. Another opportunistic infection that may hit the brain is toxoplasmosis, which is caused by the parasite Toxoplasma gondii. Individuals usually get infected from contact with cat feces as well as consumption of undercooked meat, especially pork and lamb. In severely immunocompromised individuals, toxoplasma may spread to the brain, causing cerebral toxoplasmosis. This may present with a headache, fever, and neurological symptoms like weakness, speech difficulties, and seizures. Now, cerebral toxoplasmosis is characterized by multiple brain abscesses. So in a test question, a big clue for the diagnosis would be a CT scan or MRI showing multiple ring-enhancing lesions with central necrosis. Moving on, another important parasite here is Cridosporidium sip, which causes cryptosporidiosis. The main symptom is chronic watery diarrhea associated with abdominal pain. Diagnosis can be confirmed via stool samples, showing oocyst upon acid-fast staining. Then there's Candida albicans again. But when the T-cell count falls below 100, it can progress from the oral cavity to the esophagus, resulting in esophagitis. What's high yield is that with upper endoscopy, you'd be able to find white plaques surrounded by erythema, or reddening of the mucosa. The diagnosis of Candida esophagitis can be confirmed upon biopsy, where the most high-yield finding is the presence of pseudohyphae. Now, bear in mind that esophagitis may also be caused by cytomegalovirus, or CMV. In this case, upper endoscopy may reveal large superficial linear ulcers, surrounded by normal-appearing mucosa. CMV may also cause retinitis, or inflammation of the retina, where fundoscopy shows fluffy white patches called cotton wool spots. Finally, remember that CMV may also present with colitis, encephalitis, and pneumonia, which are inflammation of the colon, brain, and lungs, respectively. For diagnosis, a biopsy specimen shows enlarged cells with the characteristic owl's eye inclusion bodies within their nuclei. Another virus that makes a comeback here is Epstein-Barr virus, which remember leads to oral hairy leukoplakia, when cell count falls below 500. Now, EVB also infects B cells, which are normally killed off by T cells. But with a T cell count below 100, the infected B cells are free to survive and proliferate. This can lead to B cell lymphomas, including both Hodgkin's lymphoma and non-Hodgkin lymphoma, especially Burkitt lymphoma, and primary central nervous system or CNS lymphoma. And if there's a single fact you must absolutely remember here, is that CNS lymphoma can be detected with a CT scan or MRI, which usually shows a solitary or single ring enhancing lesion, in contrast with the multiple lesions found in cerebral toxoplasmosis. Then, there's bacillary angiomatosis, a form of cat scratch disease caused by Bartonella hensleyi. This bacterium leads to benign papular vesicular lesions on the skin, very similar to those seen in Kaposi's sarcoma. To set these two apart, remember that in bacillary angiomatosis, biopsy typically shows neutrophilic inflammation, meaning that it mostly consists of neutrophils, whereas in Kaposi's sarcoma, there's lymphocytic inflammation. Last but not least, there's Mycobacterium avium complex, or MAC for short. This is a group of mycobacteria, similar to Mycobacterium tuberculosis, so they can also infect the lungs, causing non-tuberculosis mycobacterial lung disease. Although this can affect people with a T-cell count below 100, keep in mind that it's particularly common when the T-cell count falls below 50. In addition, these individuals are more likely to develop disseminated infection, which can present with nonspecific systematic symptoms like fever, night sweats, and weight loss, as well as focal lymphadenitis, meaning swollen lymph nodes that are mainly on one side of the neck. When disseminated MAC is suspected, a blood culture is necessary to confirm the diagnosis. Wow, that was a lot. To help you remember the 4 clinical stages of untreated HIV infection, think of the 4 F's. The first F stands for the flu-like symptoms, characteristic of the acute stage. Then the second F is when the person feels fine during the clinically latent stage. After that, there's a falling count of CD4 plus T cells, which leads to the symptomatic stage. And lastly, there's the final crisis, where HIV infection progresses to AIDS. Now, for your exams, you must also be able to recognize the neonatal manifestations of HIV infection. which remember can be passed by the mother. The thing with neonatal manifestations is that they're nonspecific and varied, but for your exams, be sure to remember the most high-yield ones, which include generalized lymphadenopathy, and oral candidiasis, as well as chronic diarrhea, failure to thrive, and developmental delay. In addition, neonates who progress to AIDS may develop recurrent bacterial infections as well as opportunistic infections such as Pneumocystis jirovecii or cytomegalovirus. Now, a real favorite for examiners is the diagnosis of HIV infection. The first step usually involves an HIV-1, HIV-2 antigen-antibody immunoassay, which can detect both the virus directly by looking for the P24 capsid protein, as well as the antibodies that the body has made against the virus. Now, this immunoassay has a very high sensitivity and specificity, so individuals who get a negative test don't need to be further tested. However, what's really important to know is that a positive immunoassay result gives a presumptive diagnosis, which means that the infection is likely, but still needs to be confirmed with another test. In the past, the confirmatory test of choice used to be a Western blot, which allows to detect antibodies against HIV, but keep in mind that this is no longer recommended by the CDC. Nowadays, the next step is to perform an HIV-1, HIV-2 antibody differentiation immunoassay, which allows to detect specific antibodies for each type. If this immunoassay turns out positive for either or both HIV types, then the diagnosis is confirmed. On the flip side, if the result of this test is negative for both or indeterminate, then a third test is recommended, the HIV-1 nucleic acid test, or NAT for short. This test can detect the virus directly by looking for its RNA. So this is it. If it's positive, then the person is definitely infected with HIV-1. And if it's negative, they're not infected by HIV-1, which means the first antigen-antibody immunoassay was a false positive. Now, once the diagnosis of HIV infection is confirmed, it is important to determine if the disease has progressed to AIDS. To do that, you should check the T cell count, which, remember, would be lower than 200 cells per cubic millimeter, and assess for the presence of AIDS-defining conditions. Finally, an important thing to determine is the prognosis. This is usually done via an HIV viral load test, which allows to determine the amount of viral RNA in the individual's blood. And higher viral loads are usually associated with poor prognosis. Now, HIV viral load tests can also be done to monitor the effect of treatment over time, in which case a decrease in viral load means the treatment is working. Now, to diagnose HIV in newborns, bear in mind that HIV-1 and HIV-2 antigen immunoassays are not reliable. That's because maternal antibodies may have crossed the placenta during pregnancy, resulting in false positive results. So HIV diagnosis in newborns is usually made with HIV viral load tests, and it's confirmed when at least 2 tests from different blood samples are positive. Unfortunately, there's no cure for HIV yet. However, there are some treatment options that can help affected individuals live longer, as well as reduce the risk of transmission. HIV therapy should be started as soon as possible at the time of diagnosis. And remember that it's especially urgent for individuals who already present with a CD4+ cell count below 500 cells per cubic millimeter, a high viral load, or AIDS-defining conditions. HIV therapy involves the use of antiretroviral medications, which help slow down HIV replication, giving the immune system a chance to recover and help fight off other infections more effectively. For your exams, there are 4 main classes of antiretrovirals. The first and most widely used one are reverse transcriptase inhibitors, which inhibit the reverse transcriptase enzyme, preventing it from reverse transcribing the viral RNA into proviral DNA. Based on their structure, reverse transcriptase inhibitors can be classified into nucleoside reverse transcriptase inhibitors, or NRTIs, which include zidovudine, stavudine, lamivudine, didanosine, abacavir, and tenofovir, or non-nucleoside reverse transcriptase inhibitors, or NNRTIs, such as efavirenz and nevirapine. The second antiretroviral class are integrase inhibitors, which inhibit the viral integrase enzyme needed to incorporate the proviral DNA into the host cell's DNA. Some important integrase inhibitors include drugs like raltegravir, elvitegravir, and dolutegravir. And a tip to recognize them on a test question is that they all have tegra in the middle. The third class are protease inhibitors, which work by inhibiting the protease enzyme, preventing the cleavage of viral envelope glycoproteins. Common protease inhibitors include atazanavir, darunavir, indinavir, lopinavir, saquinavir, and ritonavir, all ending in navir. And the fourth antiretroviral class are entry inhibitors, which act by preventing the binding of HIV to the CD4 protein, thereby preventing its entry into the host cell. Entry inhibitors include enfuvirtide and maraviroc. Now, a very important concept to recall here is that HIV has a tendency to acquire mutation. So, if an individual is treated with only one antiretroviral medication, the virus can end up mutating around that medication and ultimately become resistant to it. To prevent drug resistance, HIV is usually treated with a combination of 3 antiretroviral medications. This regimen is called antiretroviral therapy, or ART. Now, when selecting the appropriate ART regimen that's tailored to each individual, an HIV drug resistance test is recommended. This usually involves HIV genotyping, which examines the genetic structure of the individual's HIV strain to determine whether it is resistant to any antiretroviral medication. For your exam, remember that the most frequently used regimen includes 2 NRTIs, along with 1 antiretroviral of another class, which is most often an integrase inhibitor. In general, most ART regimens are effective against both HIV-1 and 2. But bear in mind that NNRTIs and the entry inhibitor or enfuvirtide are not effective against HIV-2. With pregnant individuals who have been newly diagnosed with HIV, the course of action is pretty much the same. That means starting ART as soon as possible, which is extremely important to reduce the risk of mother-to-child transmission. For your exams, remember that the most commonly used regimens for pregnant individuals include the NRTIs zidovudine and lamivudine, which are usually combined with an NNRTI like efavirenz. But this isn't the only way to prevent HIV transmission to the baby. Firstly, if a pregnant individual that's approaching the expected due date has high or unknown viral loads, it is recommended that they get a cesarean or C-section. This is usually scheduled 2 weeks before their due date to prevent the onset of spontaneous labor that would increase the risk of transmission. After delivery, neonates are treated with zidovudine as prophylaxis during the first 4 to 6 weeks of age. In addition, breastfeeding is contraindicated, since breast milk can carry the virus. Now, individuals who progress to AIDS should also receive prophylactic treatment to prevent certain AIDS-defining conditions. Those with a T-cell count below 200 cells per cubic millimeter should get antibiotic prophylaxis with trimethoprim sulfamethoxazole against pneumocystis jirovecii and toxoplasma. In addition, those with a T-cell count below 50 cells per cubic millimeter should get antibiotic prophylaxis with azithromycin or clarithromycin against Mycobacterium avium complex. Alright, as a quick recap. HIV is a single-stranded positive sense enveloped RNA retrovirus which can be transmitted via contact with certain body fluids including blood, genital fluids like semen or vaginal discharge, and breast milk. Once inside the body, HIV infects macrophages and T helper cells, using as a receptor the CD4 protein, and as a co-receptor either CCR5 or CXCR4. If untreated, HIV infection has 4 stages that can be remembered as the 4 Fs. The first F stands for flu-like symptoms, characteristic of the acute stage. The second F is when the person feels fine during a clinically latent stage. After that, there's a falling count of CD4 plus T cells, below 500 cells per cubic millimeter, which leads to the symptomatic stage, where minor infections might arise. Finally, there's the final crisis, where T cells fall below 200 cells per cubic millimeter, and HIV infection progresses to AIDS. At this stage, individuals may present with fever, fatigue, unintentional weight loss, and diarrhea. In addition, they may develop AIDS-defining conditions, such as certain cancers or severe opportunistic infections, and ultimately die. For diagnosis, the first step usually involves an HIV-1, HIV-2 antigen-antibody immunoassay. A positive result gives a presumptive diagnosis that needs to be confirmed with an HIV-1, HIV-2 antibody differentiation immunoassay. If the result is negative or indeterminate, then diagnosis should be confirmed with an HIV-1 nucleic acid test. Finally, an HIV viral load test can be done to determine the prognosis and monitor the effect of treatment over time. Treatment involves antiretroviral therapy, or ART, which combines 3 drugs to prevent resistance. The typical regimen includes 2 nucleoside reverse transcriptase inhibitors, or NRTIs for short, along with 1 antiretroviral medication of another class, preferably an integrase inhibitor. Other important antiretroviral classes include non-nucleoside reverse transcriptase inhibitors, or NNRTIs, protease inhibitors, and entry inhibitors. In addition to ART, individuals that progress to AIDS should get prophylactic treatment for certain AIDS-defining conditions. Now, back to our cases. David is a 42-year-old man who's presenting with fever, cough, and dyspnea. The reason why this is concerning is that David is HIV positive and has a T cell count of 180 cells per cubic millimeter. This suggests that David may have had an AIDS-defining condition. The most important clue here is the chest X-ray, which revealed ground glass opacities in both lungs. This should guide you straight to pneumocystis pneumonia. The other individual, Charles, has white plaques on both sides of his tongue, and the fact that they're unscrapable should immediately make you think of oral hairy leukoplakia. This, combined with the fact that he's been experiencing unintentional weight loss, indicate that he may have an HIV infection. This was supported by the HIV-1, HIV-2 antigen-antibody immunoassay, which turned out positive. The next step would involve confirming the diagnosis via an HIV-1, HIV-2 antibody differentiation immunoassay or an HIV-1 nucleic acid test, as well as starting Charles on the appropriate ART regimen.
"65-year-old Rebecca presents to the clinic with several months of abdominal discomfort, bloating, and a change in bowel habits. Her past medical history is significant for endometriosis. Menarche was at age 10 and menopause at age 57. She has never been pregnant. On physical examination, a slightly painful nodule is palpated around the umbilicus. Transvaginal ultrasound showed a large, irregular cyst with heterogeneous fluid in her right ovary. Later that day, 6-year-old Gloriana is brought to the office by her mother, who is worried that her daughter is more womanly and taller than other girls her age. Over the last few months, she has also occasionally complained of vague abdominal pain. Physical examination reveals coarse pubic hair and significant breast enlargement. The child's height is also in the 96th percentile. Laboratory studies also show increased inhibin B levels. Based on the initial presentation, Rebecca and Gloriana's symptoms are caused by some form of ovarian mass. Broadly speaking, ovarian masses include ovarian cysts and tumors. Starting with ovarian cysts, these are fluid-filled sacs on or in the ovaries and can be classified into simple and complex cysts. Simple cysts are generally small. They contain clear serous liquid and have a smooth internal lining. The classic example is a follicular cyst, which is a dominant follicle that fails to rupture before ovulation and keeps growing. This can happen if, say, the normal surge of LH that causes ovulation just doesn't happen during a given menstrual cycle. In fact, follicular cells are the most common type of ovarian mass in young individuals. For your test, remember that if you encounter multiple follicular cysts, they're usually associated with polycystic ovary syndrome, or PCOS. This is caused by a dysfunction in the hypothalamic pituitary ovarian axis that causes chronic anovulation, which may lead to amenorrhea, or absent menstruation, and excess androgen production, which may lead to hirsutism. Another type of simple cysts are the corpus luteum cysts. Normally, after ovulation, the follicle remnants become the corpus luteum, which regresses during the luteal phase. If, instead of regressing, the corpus luteum continues to grow, then the arteries nourishing it can rupture and hemorrhage into the cyst. So a high-yield fact to know is that corpus luteum cysts are also called hemorrhagic cysts. The last kind of simple cysts are theca-lutein cysts. These are caused by overstimulation by human chorionic gonadotropin, or HCG, a hormone that's produced by the placenta, so they're only seen in pregnancy. For your test, keep in mind that since HCG stimulates growth of the follicular theca cells and resting follicles can be found on both ovaries, these cysts are usually bilateral. Another important thing is that theca-lutein cysts are much more likely to develop when there's more HCG than usual. So the scenario will usually include multiple fetuses or gestational trophoblastic disease, like hydatidiform mole or choriocarcinoma. Okay, now the second category of cysts are complex cysts. These are generally large, have irregular borders, internal septations creating a multilocular appearance, and the fluid inside these cysts tends to be heterogeneous, meaning there's something other than fluid inside it. In many cases, a complex cyst could be part of an ovarian tumor. Speaking of ovarian tumors, they can be divided into three categories: epithelial ovarian tumors, which derive from the surface epithelium of the ovary, germ cell tumors, which derive from primordial germ cells, which are the cells that give rise to all other tissues and organs, and sex cord stromal tumors, which derive from sex cord stromal cells that originate from the connective tissue of the ovary. For your exams, remember that epithelial tumors account for over 70% of all ovarian tumors. The other 30% comes from germ cell and sex cord stromal tumors. Epithelial ovarian tumors can be subdivided into four types: serous, mucinous, endometrioid, and transitional. Serous tumors are usually cystic and full of watery fluid. Mucinous type tumors are similar to the serous type, but they're full of mucus-like fluid, which is where they get their name. Both serous and mucinous tumors can be benign, malignant, or borderline, meaning they have a mix of benign and malignant characteristics. The benign type is called serous or mucinous cystadenoma. Cystadenomas are usually a single cyst lined with simple cuboidal and columnar cells. On your test, they most commonly arise in premenopausal women who are between 30 and 40 years old. What sets them apart is that serous cystadenomas, which are the most common type of ovarian cyst, tend to be bilateral and are lined with fallopian tube-like epithelium. On the other hand, only 5 to 10% of mucinous cystadenomas are bilateral, and they are lined with mucus-secreting epithelium. The malignant type is called serous or mucinous cystadenocarcinoma. Cystadenocarcinomas have a thick, shaggy lining due to inflammation, edema, and overcrowding of the epithelial cells. They're also more common in postmenopausal women. The serous type is the most common malignant ovarian neoplasm, and they tend to be bilateral. Another high-yield fact to remember is that serous cystadenocarcinomas contain psammoma bodies, which are circular plaques of calcium deposits around necrotic or dead cells. On the other hand, an important clue to the mucinous type is that it can cause pseudomyxoma peritonei, pseudo meaning false, myxoma meaning mucinous tumor, and peritonei telling us its location. So the mucinous material can leak from the ovary into the peritoneum, resulting in metastasis to the appendix or other parts of the GI tract. Finally, there's a borderline type of both serous and mucinous tumors, and it has a mix of characteristics from both benign and malignant types. The one thing to keep in mind here is that it's usually a better outcome than the malignant type, since it's not as likely to metastasize. So then we've got tumors from endometrial cells, which are called endometriomas. These are benign cysts within the ovary that occur in endometriosis, which is when endometrial tissue from the uterus grows on the ovary. Because they're functionally the same as the endometrial tissue inside the uterus, endometriomas respond to hormones just like the uterus would. And because of this, endometriomas tend to bleed within the cyst cavity during menstruation, and over time they fill up with old blood that turns a dark brown color. Hence, examiners love to call them chocolate cysts. If these cysts get too large, they can rupture and spill their chocolate-like contents into the peritoneal cavity. Another commonly tested fact is that there's a very rare subclass of endometriomas, the endometrioid tumor, which is malignant and composed of endometrial-like glands. The last type of epithelial tumors come from transitional cells, and these are better known as Brenner tumors. They are benign and made up of bladder-like tissue, which gives them a pale yellow tan color. A high-yield fact here is that under the microscope, the cell nuclei are coffee bean-shaped. In rare cases, they can transform into squamous cell carcinoma. Alright, now that we've looked at the epithelial tumors, let's shift gears and go over the germ cell tumors. These are the second most common type, accounting for about 15% of all ovarian tumors. They can be divided into 4 subtypes, classified by the type of tissue produced by the germ cell, which are fetal, oocyte, yolk sac, and placental tissue. Starting with tumors from fetal tissue, these are called teratomas and are divided into 2 types. The first is mature cystic teratoma, also known as dermoid cyst, that has fully developed tissue inside, like skin, hair, nails, etc. These are actually the most common ovarian tumors in females between 10 and 30 years old, and are bilateral in 10% of cases. What's important here is that they tend to be benign. This is unlike mature testicular teratomas in male adults, which tend to be malignant. However, rarely, they can undergo malignant transformation into squamous cell carcinoma. A special, high-yield type of mature cystic teratoma that only contains thyroid tissue is called struma ovari. These tumors can secrete T3 and T4, leading to hyperthyroidism. So if a question asks about a female with hyperthyroidism, normal thyroid physical examination, low TSH, and an ovarian mass, think of struma ovari. The other type is immature teratoma, which has undifferentiated fetal tissue, and this is most commonly neuroectoderm, the embryonic precursor to neural tissue. For your exams, it's important to know that it tends to be malignant and very aggressive, meaning they tend to be invasive. They typically present quite early, before the age of 20. Next, tumors from oocyte tissue are called dysgerminomas, and are the most common malignant type of germ cell tumor. They are most common in adolescents. For your exams, remember that on microscopic examination, the tumor cells are large with central nuclei surrounded by clear cytoplasm. A key word for that is a fried egg appearance. Another high-yield thing to know is that this is the ovarian analog of testicular seminoma. Lactate dehydrogenase, or LDH, as well as human chorionic gonadotropin, or HCG, are both markers for this tumor. The third type of germ cell tumor comes from the yolk sac, and it's called endodermal sinus tumor. Endodermal sinus tumors are malignant and aggressive. What's high yield here is that these are the most common germ cell tumors in children. So if a test question is about a child, especially if they are younger than 3 years old with an ovarian mass, think of yolk sac tumor at the top of your differentials. Another key thing to keep in mind is that, on gross examination, they typically form a yellow hemorrhagic mass, while under the microscope we can see glomeruloid structures, or Schiller-Duval bodies. These are rings of malignant cells around the central blood vessel. Lab tests classically show elevated alpha-fetoprotein, or AFP levels. Finally, the last kind of germ cell tumor comes from the placental tissue, and it's called choriocarcinoma. These are malignant tumors which usually arise as a complication of pregnancy, but in rare cases can occur in the ovaries. Under the microscope, they contain 2 types of large cells: cytotrophoblasts, with central nuclei and pale cytoplasm, and syncytiotrophoblasts, that have multiple nuclei and darker cytoplasm. Choriocarcinomas look very similar to placental tissue, but without villi. They're usually quite small, but have a high chance of bleeding and spreading via the circulation. For your test, remember that lab tests will show extremely elevated HCG levels, which is secreted by syncytiotrophoblasts. Now, the alpha subunit of HCG is structurally similar to thyroid-stimulating hormone, or TSH for short. So, in very high concentrations, it can stimulate TSH receptors, causing symptoms of hyperthyroidism, like heat intolerance, sweating, palpitations, frequent or loose bowel movements, and weight loss. So if a question describes a female with hyperthyroidism, normal thyroid examination, an ovarian mass, plus very elevated HCG levels, it's probably choriocarcinoma of the ovaries. Okay, moving on. The third big category of ovarian tumors involves sex cord stromal tumors that originate from the connective tissue of the ovary. There are 4 main types: granulosa cell tumors, sarcomas, fibromas, and Sertoli-Leydig tumors. Granulosa cell tumor is the most common malignant stromal tumor. For your test, it's important to know that under the microscope you can see granulosa-like cells randomly arranged around pockets of eosinophilic fluid, and these are called Call-Exner bodies. Lab tests also show elevated levels of inhibin B, which is a hormone produced by granulosa cells and serves as a tumor marker. Theca cell tumors, or sarcomas, are benign tumors composed of theca cells. An extremely high-yield fact is that both granulosa and theca cell tumors are more common in postmenopausal individuals and can secrete excessive estrogen. So these tumors are associated with signs of estrogen excess, like weight gain, breast tenderness, irregular menses, and heavy menstrual bleeding, or menorrhagia. Next, fibromas are benign tumors made of bundles of fibroblasts. The important thing to remember is that they are part of Meigs syndrome, which also includes ascites, or fluid in the abdomen or peritoneal cavity, and hydrothorax, which is fluid buildup in the chest or pleural cavity. Lastly, Sertoli-Leydig cell tumors are usually benign tumors, composed of Sertoli cells and Leydig cells. These cells form testicular tubular structures lined by round Sertoli cells and surrounded by a fibrous stroma. Adjacent to the tubules, there are Leydig cells. And a key piece of information is that Leydig cells contain Ranke crystals, which are pink, rod-like crystals inside their cytoplasm. Another important thing to remember is that these tumors can be hormonally active, meaning they could secrete androgens like testosterone. For this reason, they're associated with virilization, and symptoms include acne, hirsutism, deeper voice, and hair loss. Okay, remember that all these ovarian tumors are primary, and the majority only affect one ovary. If a test question mentions bilateral ovarian masses, think of Krukenberg tumor. Krukenberg tumors are malignancies that come from the gastrointestinal system, most often a metastatic diffuse gastric carcinoma that metastasize to the ovaries. Another high-yield fact to note is that these ovarian tumors are mucin-secreting and have signet ring cells. These are cells with a large vacuole filled with mucin, which resembles the finger hole of a ring, and the nucleus is pushed towards the edge like the gemstone on the top of the ring. Now, there are plenty of risk factors associated with ovarian cancers, but the most important one you need to remember for your exams is the number of ovulatory cycles. The fewer ovulatory cycles, the smaller the risk of developing ovarian cancer. This is because ovulation requires continual replication, so the more the cells divide, the more likely they will mutate and become cancerous. So, never having been pregnant, infertility, early age of menarche, late menopause, as well as endometriosis and PCOS, due to the fact that they are both related to infertility, all increase the risk of ovarian cancer. In contrast, pregnancy, breastfeeding, and oral contraceptive use can decrease the risk due to the inhibition of ovulation. For your exams, remember that there's genetic predisposition if BRCA1 or BRCA2 mutation is present. Both of these genes are autosomal dominant. Individuals who have BRCA1 type mutation have an increased risk of both ovarian and breast cancer. But remember that ovarian cancer is usually the one with the worst prognosis. For your exam, a family history of endometrial cancer, colon cancer, or other gastrointestinal cancers can be a hint for an autosomal dominant disorder, known as hereditary non-polyposis colorectal cancer, or Lynch syndrome, where there's also a higher risk for developing ovarian cancer. Now, many ovarian cysts and tumors are asymptomatic. When there are symptoms, they are typically subtle and may include a change in bowel habits and pelvic discomfort that ranges from a pulling sensation in the groin, fullness, or bloating in the pelvis or abdomen, and dull, aching lower abdominal or pelvic pain, especially in the case of large tumors, like cystic teratomas. Large tumors can even cause ovarian torsion, where the ovary twists around the suspensory ligament. Since this ligament contains the ovarian blood vessels, torsion can cut off the blood supply to the ovary, resulting in sudden, sharp, and severe acute pelvic pain and ovarian ischemia. Since there are important symptoms associated with each of the disorders we've discussed, Let's go over the key ones again. For polycystic ovary syndrome and Sertoli-Leydig cell tumors, a key clue is amenorrhea, acne, and hirsutism, or excessive hair growth on the chin and upper lip, chest, and back. Endometriomas can cause dysmenorrhea, or painful menstruation, and are associated with fertility issues. In struma ovari, in some cases of choriocarcinoma, there will be symptoms of hyperthyroidism. Granulosa or theca cell tumors will lead to signs of estrogen excess. Prior to puberty, this results in precocious puberty, which is when signs of puberty appear before the age of 8 in females. In reproductive age, it can cause menorrhagia or metrorrhagia. In postmenopause, which is when most granulosa and theca cell tumors present, they can present with endometrial hyperplasia with uterine bleeding. Now, in more severe cases, symptoms may arise from a malignant tumor metastasizing to other organs. This can present as ascites, abdominal masses, abdominal distension, bowel obstruction, lymph node masses, or pleural effusion. An especially high-yield clue for metastatic ovarian cancer is also a Sister Mary Joseph nodule, which are bumps found around the umbilicus or belly button. However, it's extremely important to remember that in most cases, Sister Mary Joseph nodules are associated with gastric cancer. Diagnosis of ovarian cyst or tumor starts with a physical examination, which will include a pelvic examination, a blood test looking for specific tumor markers like LDH, beta-HCG, AFP, and inhibin B. Imaging studies should start with a transvaginal or abdominal ultrasound. Ultimately, a biopsy is the only way to get a definitive diagnosis of the type of cyst or tumor. CT or MRI scanning can be useful to assess if the tumor has spread. Treatment for ovarian cysts varies based on type and size. Small, simple cysts will usually get better on their own, whereas larger, complex cysts should be surgically removed. For ovarian tumors, treatment usually involves chemotherapy, surgery, and sometimes radiotherapy. Now for your exams, it's important to know that the levels of carbohydrate antigen 125, or CA125, are tumor markers used to monitor response to therapy and potential relapse. It's not specific enough to be used for diagnosis or screening. Alright, as a quick recap. Ovarian cysts can broadly be grouped as simple and complex cysts. Simple cysts include follicular cysts, luteal cysts, and theca-lutein cysts. Complex cysts frequently occur with ovarian tumors. The most common type of ovarian tumors are epithelial tumors, which can be serous, mucinous, endometrioid, and transitional. Next are the germ cell tumors, which include teratomas, which can be mature and benign or immature and malignant. Dysgerminomas, which are malignant and affect adolescents. Yolk sac tumors, which are the most common type in children. And choriocarcinomas, which are associated with hyperthyroidism. Sex cord stromal tumors include granulosa cell tumors, which are malignant, and thecomas, which are benign. Both are associated with precocious puberty or abnormal vaginal bleeding. Fibromas are benign and are part of Meg syndrome, while Sertoli-Leydig cell tumors can secrete excess androgens. Finally, bilateral ovarian tumors usually arise from metastatic gastric carcinomas and are known as Krukenberg tumors. Now, risk of ovarian tumors increases with the number of ovulation cycles. Mutations in the BRCA1 and 2 gene and Lynch syndrome are also associated with an increased risk of developing ovarian tumors. Alright, back to our cases. Rebecca presented with vague symptoms like abdominal discomfort, bloating, and a change in bowel habits, but she also had a Sister Mary Joseph nodule on physical exam. These point to a possible ovarian carcinoma. Her ultrasound showed a complex ovarian cyst, which is also characteristic of ovarian cancer. Other clues include her past history of endometriosis, early age of menarche, late menopause, and nulliparity, which are common risk factors for ovarian cancer. This was confirmed with a biopsy, which revealed a serous cystadenocarcinoma, the most common type of ovarian cancer. On the other hand, Gloriana came in with signs of precocious puberty, abdominal pain, and elevated inhibin B levels, which make us suspicious for a granulosa theca cell tumor. Microscopic examination of the tumor confirmed the presence of the classic Call-Exner bodies.
A 35-year-old female named Ray comes to the clinic one day with complaints of multiple verrucous skin lesions that have appeared over the anogenital region. Upon further questioning, Ray tells you that her husband also developed the same lesions over the same region a few weeks ago, but hasn't sought medical attention. On physical examination, you notice that the skin lesions are soft and flesh-colored and have a unique cauliflower-like appearance. You decide to perform a biopsy of the lesion, which reveals the presence of multiple vacuolated epithelial cells with enlarged irregular nuclei. A few days later, a 30-year-old male named Mark comes to the clinic concerned about a painful ulcer that recently developed in his genital region. Upon further questioning, he mentions that he's sexually active, but doesn't always use protection. On examination of the genital region, you notice that the ulcer is covered by exudate. In addition, Mark has inguinal lymphadenopathy, which is tender. You obtain a sample of the exudate and order a gram staining, which shows gram-negative rod-shaped bacteria arranged in parallel strands. Now, based on the initial presentation, Ray has warts while Mark has ulcers, and both cases seem to be caused by a sexually transmitted infection, or STI for short. STIs are mainly transmitted from person to person during sexual contact through bodily fluids, such as vaginal secretions, semen, or blood. The ones most at risk of contracting an STI are sexually active individuals, particularly those who have unprotected sex or multiple sexual partners. But it's important to note that sexually transmitted infections can also be transmitted via contact with skin or mucous membranes, including eyes, mouth, throat, and anus. And that's a high-yield fact. Now, a common STI that may cause warts, called Condylomata acuminata, is caused by human papillomavirus, or HPV. On the other hand, STIs that may cause ulcers include genital herpes, caused by herpes simplex virus, or HSV, syphilis, caused by Treponema pallidum, lymphogranuloma venereum, which is caused by Chlamydia trachomatis, granuloma inguinale, caused by Klebsiella granulomatis, and chancroid, which is caused by Haemophilus ducreyi. All right, let's begin with Condylomata acuminata, which are anogenital warts, or verrucae. Now, Condylomata acuminata are caused by the human papillomavirus, or HPV. As a side note, remember that there are over 100 different serotypes of HPV, among which serotypes 16 and 18 have a high risk of transforming into malignant lesions or cancers of the cervix, vagina, vulva, penis, anus, and oropharynx. In contrast, Condylomata acuminata are caused by low-risk HPV serotypes 6 and 11, so they are benign lesions. In a test question, look for lesions that are soft, flesh-colored, and have a cauliflower-like look to their surface. Though they are typically painless, they can cause itching or bleeding. For diagnosis, a high-yield finding upon biopsy is coilocytosis, which refers to the presence of multiple vacuolated epithelial cells with enlarged irregular nuclei. Treatment of Condylomata acuminata involves removal with topical medications, like imiquimod, or techniques like cryotherapy or surgical excision. Next up, genital herpes infection is caused by the herpes simplex virus, primarily by serotype 2, or HSV2, and sometimes serotype 1, or HSV1. HSV is most often transmitted through direct contact with active herpes lesions, but can also be transmitted through saliva or genital secretions of infected individuals. When a person gets infected by HSV2, at first it enters the skin cells where it starts replicating. As a result, individuals develop painful and itchy vesicles and ulcers over the genital area. In addition, there can be tender inguinal lymphadenopathy, as well as systemic symptoms like fever, headache, and myalgia. HSV2 can also infect nearby neurons and travel up their axon to the neuron's cell body, where it remains latent. So that's ultimately where the virus settles for life. For your exams, remember that HSV2 typically remains latent in the sacral ganglia. From time to time, the virus can reactivate and travel back down the axon to the skin cells. As a result, infected individuals can develop genital vesicles and ulcers over and over again throughout their lifetime, with classic triggers including stress, skin damage, and other viral illnesses. Keep in mind that genital herpes during pregnancy can spread to the fetus through the placenta, or during childbirth, when the baby passes through infected vaginal secretions. Neonatal herpes presents with the characteristic vesicular skin lesions, which mainly involve the scalp, the eyelid margins, and the oral mucosa, but can also lead to meningoencephalitis, or inflammation of the meninges and the brain. Now, diagnosis of HSV infection can be made by collecting a sample from a skin lesion and performing a viral culture, or a PCR. In addition, a Zank smear can be done, which shows multinucleated giant cells with intranuclear inclusion bodies, known as Cowdrey A bodies. Finally, serology can help identify anti-HSV antibodies. Although genital herpes typically resolves without treatment within a couple of weeks, treatment with antiviral medications like valacyclovir or acyclovir can help reduce pain and speed up healing. Another common STI that causes ulcers is syphilis, which is caused by the spirochete Treponema pallidum. Now, syphilis is a progressive disease that has 3 stages. The first stage is called primary syphilis, or early localized stage, and it's characterized by the presence of a solitary, painless genital ulcer called a chancre, which has a hard base, raised borders, and is usually covered by an exudate that's rich in spirochetes. Generally, the chancre can appear anytime within 3 weeks from the initial infection, and typically heals on its own without any treatment within 3 to 6 weeks. However, during that time, some spirochetes manage to disseminate into the bloodstream. This dissemination leads to the second stage, called secondary syphilis, or the dissemination stage, which can occur about 2 to 10 weeks after the initial infection. Secondary syphilis may present with constitutional symptoms, such as fever, headache, and malaise, as well as generalized lymphadenopathy and patchy hair loss. But what's really important to note is that secondary syphilis is characterized by a non-itchy maculopapular rash, with small bumps that start on the trunk and spread out to the arms and legs, including the palms and soles, and eventually to the genitalia and other mucous membranes. Another typical finding in secondary syphilis is condylomata lata, which are smooth, white, painless, wart-like lesions over moist areas, like the genitals, the anal region, and the armpits. Be sure you don't get these mixed up with condylomata acuminata, caused by HPV. Now, secondary syphilis usually resolves within a few weeks to months. At this point, the disease enters a dormant stage, called latent syphilis, which can last from 1 year up to even 20 years. During the latent stage, individuals are typically asymptomatic, but may still be contagious. Eventually, individuals who don't get any treatment can progress into the final stage of syphilis, which is called tertiary syphilis. Here, the immune cells start to huddle around and form characteristic granulomatous lesions, called gummas. Often, funnily enough, there aren't any spirochetes at all in these lesions. In addition to gummas, various organs get damaged during tertiary syphilis. But for your exams, the most important ones to remember are the heart and blood vessels leading to cardiovascular syphilis, as well as the brain and spinal cord, leading to neurosyphilis. Now, in cardiovascular syphilis, there's damage to the vasa vasorum, which are the blood vessels that supply the aortic wall. This leads to syphilitic aortitis, or inflammation of the aortic wall, which can result in complications like aortic aneurysms. On the other hand, neurosyphilis presents with symptoms of meningitis, such as a fever, headache, and neck stiffness. Over time, neurosyphilis can lead to altered mood and behavior, as well as confusion and dementia. Additionally, neurosyphilis can cause slow and progressive degeneration of the spinal column, leading to a loss of the sensations of pressure, fine touch, vibrations, and proprioception. This is also known as tabes dorsalis. For your test, you need to know that without the sensations of vibration and proprioception, the individual will often lose coordination and experience difficulty walking. As a result, they may present with wide-based ataxia, meaning that they stand or walk with their feet spaced widely apart. Another telltale finding is a positive Romberg sign, which means that they can't maintain balance with their eyes closed. Neurosyphilis can also result in general paresis, weakness, or sometimes even paralysis, mostly in the legs. Finally, neurosyphilis can affect the eye, causing an Argyll-Robertson pupil. This means the pupils lose their light reflex, so they do not constrict when exposed to light, but they still have their accommodation reflex, so they do constrict when focusing on an object that is close by. Now, keep in mind that syphilis can also be passed during pregnancy to the fetus, causing congenital syphilis. This often results in hydrops fetalis, which is when the fetus has an abnormal accumulation of fluid in soft tissues. This poses a great risk for stillbirth, which is when the fetus dies within the womb. Babies who survive the pregnancy typically develop some characteristic features, such as frontal bossing, a saddle nose, and a short maxilla. Now, diagnosis of syphilis starts with identifying spirochetes in the exudate from the chancre, and this can be done using dark field microscopy. In addition, there are serological tests for syphilis, which are divided into non-treponemal tests and treponemal tests. Non-treponemal tests assess if the individual has antibodies that react to a beef cardiolipin antigen. And some examples you must absolutely remember include rapid plasma reagin, or RPR test, and venereal disease research laboratory, or VDRL test. Keep in mind, though, that non-treponemal tests are nonspecific for syphilis and can give false positive results in the case of other infectious diseases, such as infectious mononucleosis, hepatitis, and leprosy, as well as in certain autoimmune diseases, like systemic lupus erythematosus, antiphospholipid antibody syndrome, and rheumatoid arthritis. False positives may also occur during pregnancy and in those who take certain medications, like chlorpromazine and procainamide, and that's very high yield. On the other hand, treponemal tests are specific tests for syphilis that detect antibodies against treponemal antigens. Important examples include fluorescent treponemal antibody absorption, or FTA-ABS, treponema pallidum particle agglutination assay, or TPPA, and microhemagglutination test for antibodies to treponema pallidum, or MHA-TP. What's important to know is that generally individuals are first tested with a non-treponemal test, and if that comes out positive, a treponemal test like FTA-ABS is performed. If the treponemal test is also positive, diagnosis of syphilis is confirmed, but if it's negative, then the initial non-treponemal test is considered a false positive. Treatment of syphilis is typically with intramuscular penicillin G. When using penicillin, though, look out for a Jarisch-Herxheimer reaction, which is when large numbers of spirochetes die and break open, releasing a lot of antigens all at once. As a result, the immune system goes into overdrive, causing a flu-like syndrome with sudden fever, sweating, and muscle and joint pain, which may last for a few hours to a few days. Jarisch-Herxheimer reaction is usually treated with supportive care. Another STI that may cause ulcers is lymphogranuloma venereum, or LGV for short. This is caused by serotypes L1, L2, and L3 of Chlamydia trachomatis, which is a gram-negative obligate intracellular bacterium, meaning that it needs to infect and enter a host cell to be able to replicate. Initially, LGV can present with skin lesions over the genital area, such as painless small papules or granulomas, as well as shallow ulcers. These lesions tend to heal very quickly and often go unnoticed by the individual. After about 2 to 4 weeks, LGV moves on to infect the inguinal lymph nodes. As a result, individuals develop painful inguinal lymphadenopathy, or enlarged lymph nodes, called buboes. If not treated, buboes can become inflamed and fixate on the overlying skin, leading to complications like abscesses, fistulas, or necrosis. Treatment typically involves antibiotics like doxycycline or azithromycin. Moving on, the next bacterial STI is granuloma inguinale, also called donna venosus, or granuloma venereum. But make sure you don't confuse this with lymphogranuloma venereum. Now, granuloma inguinale is caused by Klebsiella granulomatis, which is a gram-negative obligate intracellular bacterium. For your exams, note that granuloma inguinale is very uncommon in the United States, but can still be encountered in tropical countries, such as India, Papua New Guinea, the Caribbean, South America, and Australia. So in a test question, look for an individual who's traveling from these countries. Typically, granuloma inguinale begins with a painless papule or granuloma over the genital area. The papule then progresses to an extensive but still painless ulcer, which is highly vascular. This gives the ulcer a beefy red appearance and causes it to bleed easily when touched. Another high-yield fact is that unlike other bacterial STIs like lymphogranuloma venereum or syphilis, granuloma inguinale does not usually cause lymphadenopathy. Now, diagnosis of granuloma inguinale can be confirmed by collecting a smear or biopsy of the ulcer, which reveal the characteristic Donovan bodies, which are gram-negative cytoplasmic bacteria within the host cells that resemble safety pins on microscopic examination. Treatment of granuloma inguinale usually involves at least 3 weeks of antibiotics, most often with oral azithromycin. Last but not least is chancroid, which is caused by the gram-negative bacterium Haemophilus ducreyi. Now, the hallmark symptom of the chancroid is a painful ulcer with soft, irregular margins that develops over the genital region. The base of the ulcer is usually covered with purulent exudate and may bleed easily when touched or scraped. Now, for your exams, remember that the ulcers in other bacterial STIs, such as lymphogranuloma venereum, syphilis, and granuloma inguinale, are painless. So what sets chancroid apart is that the ulcer is painful. So painful, you do cry. Get it? In addition, many cases of chancroid can present with painful inguinal lymphadenopathy. And that's an important difference with granuloma inguinale. Chancroid can be diagnosed by PCR, culture, and gram staining of the ulcer exudate. What's unique about chancroid is that the gram stain shows gram-negative rods arranged in a parallel formation, also called school of fish appearance. Treatment of chancroid typically involves a single dose of antibiotics, most often with oral azithromycin, or an intramuscular injection of ceftriaxone. All right, as a quick recap, condylomata acuminata are caused by low-risk HPV serotypes 6 and 11. and manifest as benign anogenital warts that are typically soft, flesh-colored, and have a cauliflower-like look. For diagnosis, a characteristic finding upon biopsy is coilocytosis, and treatment involves removal. Genital herpes is most commonly caused by HSV-2 and presents with painful and itchy vesicles and ulcers, as well as tender inguinal lymphadenopathy, and systemic symptoms like fever, headache, and myalgia. Diagnosis can be done with viral culture, PCR, and a Zank smear to show multinucleated giant cells with Cowdrey A bodies, and treatment can involve acyclovir. Syphilis is caused by Treponema pallidum. Primary syphilis presents with a painless chancre. Secondary syphilis presents with constitutional symptoms and generalized lymphadenopathy, as well as a maculopapular rash that starts on the trunk and spreads out to the rest of the body, including the palms and soles, and condylomata lata over the genital area. Finally, tertiary syphilis is characterized by gummas and may lead to cardiovascular syphilis or neurosyphilis. Diagnosis can involve dark field microscopy of the chancre exudate, non-treponemal tests like RPR and VDRL, and treponemal tests like FT-ABS, TPPA, and MHA-TP. Treatment of syphilis involves penicillin G, but look out for a Jarisch-Herxheimer reaction. Lymphogranuloma venereum is caused by Chlamydia trachomatis serotypes L1, L2, and L3, and presents with painless genital ulcers, as well as painful and enlarged inguinal lymph nodes, called buboes. Granuloma inguinale, or donovanosis, is caused by Klebsiella granulomatis, and presents with a painless, beefy red ulcer that bleeds easily when touched. Diagnosis involves the detection of Donovan bodies on microscopic examination. Chancroid is caused by Haemophilus ducreyi and presents with painful genital ulcers covered with purulent exudate, as well as painful inguinal lymphadenopathy. For diagnosis, Gram stain shows a characteristic school of fish arrangement. Okay, back to our cases. Ray is a 35-year-old female who presents with multiple anogenital warts. A relevant clue is the fact that her husband also developed the same lesions over the same region, which indicates that it's probably a sexually transmitted infection. The most important clue, though, is physical examination, which reveals a soft, flesh-colored lesion with a unique cauliflower-like appearance. This should already point you to the right answer, that Ray presents with condylomata acuminata. But, as a bonus finding, there's coilocytosis upon biopsy, which confirms the diagnosis. On the other hand, Mark is a 30-year-old male with a history of unprotected sexual contact, and presents with a genital ulcer with exudate associated with tender inguinal lymphadenopathy. This presentation is very common among many STIs. So a big clue here is that the ulcer is painful, which points to either genital herpes or chancroid. The real key is the exudate Gram staining, which reveals Gram-negative rods arranged in a school of fish pattern, confirming the diagnosis of chancroid.
A 26-year-old female named Anna comes to the clinic one day with complaints of painful and more frequent urination, as well as pain during sexual intercourse and increased vaginal discharge for the past 5 days. Upon further questioning, Anna tells you that she's had multiple sexual partners lately. On physical examination, there's purulent vaginal discharge. You obtain a discharge sample with a swab and perform a Gram stain, which reveals the presence of Gram-negative diplococci bacteria within neutrophils. You prescribe her a combination of azithromycin and ceftriaxone. A year later, Anna comes back with similar complaints, but this time she also has a fever and lower abdominal pain that worsens when she moves. Upon further questioning, Anna reveals that she's had 2 more episodes of vaginal infections over the past year, but she didn't seek medical attention. On physical examination, you notice that Anna has a fever, and when you perform a gynecological exam, movement of the cervix elicits pain. Now, based on the initial presentation, Anna seems to have vaginitis or cervicitis caused by a sexually transmitted infection, or STI for short. STIs are mainly transmitted from person to person during sexual contact through body fluids such as vaginal secretions, semen, or blood. The ones most at risk of contracting an STI are sexually active individuals, particularly those who have unprotected sex or multiple sexual partners. But it's important to note that sexually transmitted infections can also be transmitted via contact with skin or mucous membranes, including eyes, mouth, throat, and anus. And that's a high-yield fact. Now, STIs that may cause vaginitis and cervicitis include chlamydia, which is caused by Chlamydia trachomatis, gonorrhea, which is caused by Neisseria gonorrhoeae, and trichomoniasis, caused by Trichomonas vaginalis. Now let's begin with Chlamydia trachomatis, which is a gram-negative obligate intracellular bacterium, meaning that it needs to infect and enter a host cell to be able to replicate. For your exams, it's important to remember that Chlamydia trachomatis has 15 serotypes. Serotypes A through C are typically transmitted through contact with secretions from the eyes, nose, or throat of an infected person and cause chlamydial conjunctivitis, also called trachoma. If untreated, trachoma can ultimately destroy the cornea, resulting in total blindness. Serotypes D through K of Chlamydia trachomatis are typically transmitted via sexual contact and cause the STI chlamydia. Now, keep in mind that in both sexes, chlamydia is usually an asymptomatic infection of the genitourinary tract. But what's important to know for your exams is that symptomatic individuals typically present with mucopurulent discharge, dysuria or pain and burning during urination, and increased urinary frequency. In males, serotypes D through K can infect the urethral mucosa, causing urethritis. Also, it can cause inflammation of the epididymis or epididymitis, as well as testicular pain and swelling. Sometimes the infection can spread to the prostate, resulting in prostatitis. On the other hand, some females may also develop urethritis, but most often, chlamydia affects the lower genital tract, causing vulvovaginitis or inflammation of the vulva and vagina, and cervicitis when the cervix is involved. This may present with changes in vaginal discharge, intermenstrual and postcoital vaginal bleeding, and dyspareunia or pain during sexual intercourse. Now, an important complication in females is pelvic inflammatory disease, which is when the infection spreads to the uterus, fallopian tubes, and ovaries, leading to lower abdominal pain and fever. If left untreated, chlamydia can cause infertility in both males and females. Now, in some cases, chlamydia can trigger reactive arthritis, which is an autoimmune condition that leads to inflammation of joints, and what's important to remember is that reactive arthritis develops up to 3 weeks after the initial infection. Now, if chlamydia affects a pregnant individual, there is risk for the infection to be passed down to the baby during vaginal delivery. This can result in neonatal conjunctivitis, which appears 1 to 2 weeks after birth. Alternatively, if the bacteria make their way down the baby's respiratory tract, it can result in neonatal pneumonia. The most characteristic symptom of neonatal pneumonia is staccato cough, meaning short, repetitive coughing with deep inspiration after each single cough. Lastly, serotypes L1, L2, and L3 of Chlamydia trachomatis are also transmitted through sexual contact, but they cause a disease called lymphogranuloma venereum, or LVG for short. LVG is characterized by skin lesions over the genital area, such as painless small papules or granulomas and shallow ulcers, as well as painful inguinal lymphadenopathy or enlarged lymph nodes called buboes. Diagnosis of infection by Chlamydia trachomatis can be confirmed by taking a genital swab or urine sample and looking for the bacterial DNA with nucleic acid amplification testing, or NAAT, or a polymerase chain reaction, or PCR. Keep in mind that Chlamydia trachomatis does not gram stain well, mainly because it's an obligate intracellular bacterium. So infected cells can be examined on a sample smear with a Giemsa stain or direct fluorescent antibody stain, revealing the presence of intracellular or cytoplasmic inclusions with reticulate bodies, which are the replicating forms of Chlamydia trachomatis within the host cells. Treatment involves antibiotics that inhibit the synthesis of bacterial proteins, such as macrolides like azithromycin, or tetracyclines like doxycycline. Now, keep in mind that genitourinary infection with chlamydia is frequently associated with co-infection by Neisseria gonorrhoeae. For that reason, ceftriaxone is usually added to also cover Neisseria gonorrhoeae, and that's very high yield. Now, Neisseria gonorrhoeae is a gram-negative diplococcus that causes the STI gonorrhea, which has a clinical presentation that's very similar to chlamydia. So, individuals typically present with mucopurulent discharge, as well as dysuria and increased urinary frequency. In males, gonorrhea can result in urethritis, epididymitis, or prostatitis, while in females, it may cause vaginitis, cervicitis, and pelvic inflammatory disease. However, differently from chlamydia, Neisseria gonorrhoeae can spread through the bloodstream and directly infect a joint, causing septic arthritis. Now, infection during pregnancy can spread to the baby during vaginal delivery and results in early neonatal conjunctivitis, which appears 2 to 5 days after birth. Diagnosis of gonococcal infection can be done by taking a genital swab or urine sample and looking for the bacterial DNA with NAAT or PCR, or by growing the bacteria on Thayer-Martin agar, which is a selective medium for Neisseria gonorrhoeae. Additionally, on gram staining, you'd find pink coffee bean-shaped bacteria within neutrophils. Treatment for gonococcal infections is with third-generation cephalosporins, typically ceftriaxone, which is typically combined with antibiotics against chlamydia, so azithromycin or doxycycline, due to frequent co-infection. Now, an important complication of vaginitis and cervicitis is pelvic inflammatory disease, or PID for short. This occurs when the infection spreads from the vagina or cervix into the upper female reproductive system. This can involve the uterus, causing endometritis, the fallopian tubes, causing salpingitis, and the ovaries, causing oophoritis. Now, the vast majority of cases are due to chlamydia and gonorrhea, but occasionally, PID can be caused by other types of bacteria introduced into the reproductive tract during procedures like surgery or even vaginal childbirth. Most of the time, the infection is caused by only one type of bacteria, but in some cases it becomes polymicrobial. Now, PID may present with fever, dyspareunia, and lower abdominal pain that worsens with sudden movement. In fact, a telltale sign of PID is cervical motion tenderness, which is when mobilizing the cervix during a vaginal exam causes pain or discomfort. And that's a high-yield fact. In addition, the strong inflammatory response in PID results in damage to the fallopian tubes, which become filled with pus, so individuals typically present with purulent discharge. As the damaged tissue heals, scar tissue forms in the fallopian tubes. This scarring can lead to a number of complications, such as chronic pelvic pain, as well as adhesions and strictures of the fallopian tubes, subsequently increasing the risk of ectopic pregnancy and infertility. If pus builds up in the scarred tube and ovary, it can turn into a tubo-ovarian abscess, which is an encapsulated pocket of pus that can rupture and spread into the bloodstream, leading to sepsis. One last complication of PID is Fitzhugh-Curtis syndrome, or parahepatitis, which occurs when the infection spreads to the peritoneum and, from there, to Glissen's capsule, which is a layer of connective tissue that surrounds the liver. This results in violin string adhesions of scar tissue that attach the liver to the peritoneum and may cause tenderness in the right upper quadrant of the abdomen. Diagnosis of PID involves testing vaginal discharge for the bacterial cause, and since PID can be polymicrobial, treatment involves a combination of broad-spectrum antibiotics, such as ceftriaxone, doxycycline, and metronidazole. Occasionally, surgery may be needed to treat the complications. Another high-yield STI that may cause vaginitis and cervicitis is trichomoniasis, also called Trichomonas vaginalis, which is caused by the protozoan parasite Trichomonas vaginalis. In males, trichomoniasis is usually asymptomatic, but it can cause symptoms like urethral discharge and dysuria. On the other hand, in females, symptoms include a foul-smelling, greenish, purulent vaginal discharge, along with burning and itching in the genital area. There may also be dysuria, increased urinary frequency, lower abdominal pain, and dyspareunia. What's also high yield to remember is that upon examination, the cervix may appear erythematous with punctate hemorrhages, and that's called a strawberry cervix. For diagnosis of Trichomonas vaginalis, upon saline wet mount microscopy on a discharge sample, the most high-yield finding is the presence of motile, pear-shaped trichomonads. In addition, the vaginal pH should be above 4.5, which favors the growth of the trichomonads. For treatment, it's very important to know that both the affected individual and their sexual partners should get antibiotics like metronidazole. Alright, as a quick recap, STIs that may cause vaginitis and cervicitis include chlamydia, gonorrhea, and trichomoniasis. Chlamydia is caused by serotypes D through K of Chlamydia trachomatis and primarily presents with mucopurulent discharge and dysuria. In addition, chlamydia may cause urethritis or prostatitis in males and vulvovaginitis or cervicitis in females. On the other hand, gonorrhea is caused by Neisseria gonorrhoeae and is very similar to chlamydia. Both chlamydia and gonorrhea can be diagnosed with NAAT or PCR and are usually treated with a combination of azithromycin or doxycycline plus ceftriaxone. An important complication of both chlamydia and gonorrhea is pelvic inflammatory disease, which presents with lower abdominal pain that worsens with movement, and complications include ectopic pregnancy, infertility, tubo-ovarian abscesses, and Fitzhugh-Curtis syndrome. Finally, trichomoniasis is caused by Trichomonas vaginalis and presents with foul-smelling, greenish, purulent vaginal discharge, along with burning and itching in the genital area and a strawberry cervix. Important findings for diagnosis include motile, pear-shaped trichomonads on a discharge sample, as well as a vaginal pH above 4.5, and treatment involves antibiotics like metronidazole. Okay, back to our case. Anna is a 26-year-old female, sexually active individual who presented with complaints of dysuria and increased urinary frequency, as well as dyspareunia and purulent vaginal discharge. This, combined with the fact that she's had multiple sexual partners, should make you suspect a sexually transmitted infection. The key here is the discharge swab, which revealed the presence of intracellular gram-negative diplococci bacteria within neutrophils, making this a pretty straightforward case of gonorrhea caused by Neisseria gonorrhoeae. Anna was prescribed a combination of azithromycin and ceftriaxone. A year later, Anna comes back with a similar presentation, along with a fever and lower abdominal pain that worsens with movement. An important clue is that she had 2 more episodes of vaginal infections over the past year but didn't seek medical attention. This should make you suspect that the infection might have spread into the upper female reproductive system. The final clue is the fact that Anna has cervical motion tenderness, which is typical of pelvic inflammatory disease.
Sexually transmitted infections, or STIs, are infections that get transmitted through sexual fluids or skin-to-skin contact during sexual intercourse. Some STIs primarily affect the genital organs, like gonorrhea and chlamydia, while others affect the whole body, like syphilis, HIV, and hepatitis B. Generally, with STIs, all partners with whom there has been sexual contact in the 60 days prior to the diagnosis should be evaluated and treated. On a side note, in this video we'll be using the term female to refer to individuals who have female reproductive sex organs, and the term male to refer to those who have male reproductive sex organs. Okay, let's start with infections that mainly affect the genital organs, like Neisseria gonorrhoeae, which causes gonorrhea, Chlamydia trachomatis, which causes chlamydia, and Mycoplasma genitalium, an increasingly recognized pathogen. These infections are usually asymptomatic, but in females they can cause cervicitis and urethritis. Cervicitis causes changes in vaginal discharge, pruritus in the genital area, intermenstrual vaginal bleeding, or postcoital bleeding. With urethritis, there can be symptoms that suggest a urinary tract infection, like dysuria and frequency. If left untreated, these bacteria can ascend in the reproductive tract and cause pelvic inflammatory disease, or PID, which is the inflammation of the uterus, fallopian tubes, the ovaries, and of course, the cervix. Acute PID causes lower abdominal pain that worsens during sexual intercourse or sudden movement, postcoital bleeding, and intermenstrual bleeding. Chronic PID causes a low-grade fever, weight loss, and abdominal pain. Sometimes, PID can be complicated by a tubo-ovarian abscess, which can involve the fallopian tubes, ovaries, or other nearby pelvic organs. Now in males, these infections can cause urethritis or epididymitis. With urethritis, there's dysuria and penile discharge, and with epididymitis, there's unilateral testicular pain, and a hydrocele can form around the testicle. In males and females, Chlamydia trachomatis and Neisseria gonorrhoeae can also cause conjunctivitis through direct inoculation with genital secretions. If Chlamydia trachomatis and Neisseria gonorrhoeae come into contact with anal or rectal mucosa, they can cause proctitis, and symptoms include tenesmus, anorectal pain, anorectal bleeding, and constipation. Neisseria gonorrhoeae can also cause pharyngitis, leading to sore throat, pharyngeal exudates, and cervical lymphadenitis. The gold standard for diagnosing these infections is the nucleic acid amplification testing, or NAT, from secretions. Vaginal or endocervical swabs are done for females, and urine samples or urethral swabs are done for males. If NAT is negative for Chlamydia trachomatis and Neisseria gonorrhoeae, then NAT is performed for Mycoplasma genitalium, which is another sexually transmitted infection. In males, a Gram stain is performed on the urethral swab and it's examined for the presence of white blood cells or WBCs and for bacteria. The presence of more than 2 WBCs per high power field, or HPF, suggests urethritis. In addition, the first void urine should be checked, and in urethritis, leukocyte esterase is positive on the dipstick test, and there are more than 10 WBC per HPF on microscopy. Finally, HIV testing is also done for all individuals. Neisseria gonorrhoeae can be treated with a single IM dose of ceftriaxone, either 500 mg in individuals that weigh less than 150 kg, or 1 gram in individuals that weigh more than that. Additionally, if a chlamydia infection has not been ruled out, doxycycline can be added to the treatment regimen at a dose of 100 mg twice a day for 7 days. For Chlamydia trachomatis infections, the same doxycycline regimen can be used, or, alternatively, a single 1 gram dose of azithromycin can be given orally, or a 7-day course of levofloxacin, 500 mg once daily. For individuals with epididymitis or proctitis, empirical treatment for both Chlamydia trachomatis and Neisseria gonorrhoeae infection is done with a single intramuscular dose of 500 mg or 1 gram of ceftriaxone, depending on the person's weight, as well as oral doxycycline, which can be given for 10 days in the case of epididymitis, and for 7 to 21 days for proctitis, depending on severity. For Mycoplasma genitalium infection, an empiric treatment regimen can be given 100 milligrams of doxycycline twice daily for 7 days, followed by 7 days of moxifloxacin at a dose of 400 milligrams daily. For severe PID, treatment is 1 gram of IV ceftriaxone daily, 2 grams of IV cefoxitin twice daily, or 2 grams of IV cefotetan every 6 hours, along with 100 milligrams of oral or IV doxycycline and 500 milligrams of oral or IV metronidazole every 12 hours. After 24 hours, parenteral therapy is usually switched to oral therapy with doxycycline and metronidazole for 14 days. In case there's a tubo-ovarian abscess, treatment is 100 milligrams of oral doxycycline twice daily, plus either 500 milligrams of oral metronidazole twice daily, or 450 milligrams of oral clindamycin 4 times a day for 14 days. For mild PID, treatment is a single dose of IM ceftriaxone and 100 milligrams of oral doxycycline and oral metronidazole twice daily for 14 days. Okay, now moving on to human papillomavirus infection, or HPV infection, and some serotypes like 16, 18, 52, and 56 are associated with cancer. They can cause cervical, vulvar, vaginal, anorectal, and oropharyngeal cancer in females, and penile cancer along with anorectal and oropharyngeal cancer in males. Now there are some serotypes like 6 and 11 that cause benign lesions in the genital and anal area called anogenital warts or condylomata acuminata. Anogenital warts can be located on the vulva, penis, groin, perineum, perianal skin, and sometimes on the suprapubic skin. The warts can be single or can come in groups, can have different shapes. They can be dome-shaped, plaque-like, pedunculated, verrucous, or lobulated. And they can have different colors. They can be white, skin-colored, or erythematous. The diagnosis is made on the appearance of the warts. If there's any uncertainty, the wart can be biopsied. Treatment includes topical administration of imiquimod or cinecatechins. If the lesions persist, then surgical excision, electrosurgery, cryotherapy, or treatment with trichloroacetic acid can be done. Next is Trichomonas vaginalis infection, which causes a protozoan infection called trichomoniasis. In females, symptoms include a bad-smelling, purulent, and thin vaginal discharge, along with burning and pruritus in the genital area. Additionally, there can also be dysuria, frequency, lower abdominal pain, postcoital bleeding, and dyspareunia, which is painful sexual intercourse. In males, the infection is usually asymptomatic, but it can cause symptoms like urethral discharge and dysuria. The gold standard for identifying Trichomonas vaginalis is by performing NAT on a vaginal or urethral swab. Additionally, in females, microscopy of the vaginal secretion is done, and this shows motile trichomonads. Treatment in females is done with 500 milligrams of metronidazole twice daily for 7 days. In males, a single 2-gram oral dose of metronidazole can be given. An alternative regimen for all individuals consists of a single 2-gram dose of tinidazole. Recently, a similar medication called secnidazole has also been approved for the treatment of trichomoniasis, and it's also given as a single 2-gram oral dose. Next are infections that get transmitted through skin-on-skin contact, such as pediculosis pubis infections, most commonly known as crabs, and Sarcoptes scabiei infections, which cause scabies. Both of these can infect the pubic area during sexual intercourse. The main symptom with both infections is pruritus that can involve the genital and perianal areas. With crabs, lice and nits, which are louse eggs, can be seen with the naked eye in the affected area. With scabies, there are usually multiple small erythematous papules. If the diagnosis is uncertain, then microscopic examination of hair shafts can confirm the diagnosis of crabs, and microscopic examination of a small sample of skin can confirm scabies. Crabs and scabies can be treated with topical permethrin that's applied until there are no more lesions in the genital area. And with crabs, the nits should be removed with a nit comb or tweezers. In addition, a first-line treatment for scabies is a single 200 mg dose of oral ivermectin followed by a repeat dose in 1 to 2 weeks. For crabs, some alternatives include topical malathion lotion or oral ivermectin. Another example of genital infections transmitted through skin-on-skin contact is herpes simplex virus or HSV infection. There are 2 types of herpes simplex virus, type 1 and type 2, and both can cause genital herpes. Now, the symptoms depend upon whether a person has anti-herpes simplex virus antibodies. If they don't already have those antibodies, then it's called a primary infection. In a primary infection, there are painful vesicles that form on an erythematous base, pruritus in the genital area, dysuria, and inguinal lymphadenopathy. Systemic symptoms include fever, headaches, and myalgias. Now, if the individual does have antibodies from a prior asymptomatic infection, then it's called a non-primary infection. In this case, symptoms are generally less severe. Finally, HSV can linger in the neurons and can reactivate from time to time. And when that happens, the symptoms are usually more mild. Depending on the type of sexual intercourse, herpes simplex virus can also cause proctitis, which presents with tenesmus and anorectal pain. Now, diagnosis of herpes simplex virus infection can be made with a viral culture or by doing an HSV polymerase chain reaction, or HSV PCR. Serology can also be done in order to identify anti-HSV antibodies, which diagnoses a past or present HSV infection. Treatment of primary and non-primary HSV infections is done with either oral acyclovir, 400 mg 3 times daily, or oral famciclovir, 250 mg 3 times daily, or oral valacyclovir, 1 gram twice daily. Duration of treatment is 7 to 10 days. Treatment of recurrent HSV infections depends upon the frequency of recurrent episodes and severity of symptoms. In individuals with less than 6 recurrent episodes per year, or in individuals with moderate symptoms, treatment includes oral acyclovir or oral famciclovir or oral valacyclovir for 5 days. In individuals with more than 6 recurrent episodes per year, or individuals with more severe symptoms, treatment includes long-term use of oral valacyclovir 500 mg, oral acyclovir 400 mg, or oral famciclovir 250 mg daily. Okay, another infection that's transmitted through skin-to-skin contact is Haemophilus ducreyi infection. It's thought that the microabrasions in the skin that can occur during sexual contact can create a path for Haemophilus ducreyi to infect the tissues, because this bacteria doesn't typically infect intact skin. The skin lesion starts as an erythematous papule that evolves into a painful ulcer that's about 1 to 2 centimeters in diameter that bleeds when scraped. This is called a chancroid ulcer, and usually a few ulcers develop in the genital area. In males, there's usually inguinal lymphadenopathy. In order to diagnose the infection, a gram stain, culture, and PCR can be done using exudate from the ulcer. The gram stain can sometimes show gram-negative rods in a chain, also called school of fish. Treatment is a single dose of 250 mg of IM ceftriaxone or 1 gram of oral azithromycin. Now let's switch gears and talk about infections that can affect the whole body. First, there's Treponema pallidum infection, which causes syphilis. Syphilis is divided into early and late stages. The early stage is further subdivided into primary syphilis and secondary syphilis. With primary syphilis, there's a localized skin lesion called a chancre. The skin lesion starts as an erythematous papule that evolves into a pain-free ulcer that's about 1 to 2 centimeters in diameter. Usually, a few chancre ulcers develop in the genital area. In the absence of treatment, the chancre heals within 3 to 6 weeks, but bacteria will spread throughout the body and cause a systemic infection. Within weeks to a few months after a chancre develops, secondary syphilis can occur, which is a systemic infection. General symptoms include fever, headache, malaise, anorexia, myalgias, and unintentional weight loss. Most individuals with secondary syphilis have lymphadenopathy in the posterior cervical, axillary, inguinal, and femoral regions. Often, there's a maculopapular rash that's symmetrical and diffuse and involving the trunk and extremities. There can also be gastrointestinal symptoms like right upper quadrant pain, which can be a sign of hepatitis. Renal findings include oliguria, which is less than 400 milliliters of urine per day, peripheral edema, and arterial hypertension, which can be signs of nephrotic syndrome or nephritic syndrome. Finally, there's late or tertiary syphilis, which develops in untreated individuals years or decades after the initial infection. Common manifestations are cardiovascular syphilis, which leads to a dilated ascending aorta and aortic valve regurgitation. Sometimes there can be gummatous syphilis, which is when granulomatous, irregularly shaped lesions develop in the skin, bones, and organs. Next, there's neurosyphilis, which initially causes symptoms like vision or hearing loss, as well as meningitis symptoms like fever, headache, and neck stiffness. In the late stage, neurosyphilis can lead to dementia, confusion, and reduced concentration. Additionally, there can also be tabes dorsalis, which is a slow and progressive degeneration of the posterior columns and the posterior roots of the spinal cord. Symptoms include paresthesias, pain in the extremities, loss of coordination and reflexes, muscle weakness, and difficulty walking. Now, in order to diagnose syphilis, tests are divided into non-treponemal tests and treponemal tests. Non-treponemal tests are based on the reactivity of the infected serum to a cardiolipin, cholesterol, lecithin antigen, and examples include rapid plasma reagin, or RPR, and venereal disease research laboratory, or VDRL. Now, treponemal tests detect antibodies against specific treponemal antigens, and examples include fluorescent treponemal antibody absorption, or FTABS, treponema pallidum particle agglutination assay, or TPPA, or microhemagglutination test for antibodies to treponema pallidum, or MHATP. Testing for syphilis can start with a non-treponemal test, and if this is negative and the individual is asymptomatic, then it isn't syphilis. If the non-treponemal test is reactive, then a treponemal test is done as well, and if it's still reactive, then the diagnosis of syphilis is confirmed. If the confirmatory treponemal test is negative, but the individual has a history of recent exposure to syphilis, then another confirmatory test is done in 2 to 4 weeks, and if that's positive, then the diagnosis is confirmed. If it's negative, then the non-treponemal test is considered a false positive. Sometimes a treponemal test is done initially. If it's reactive, then a non-treponemal test is done to confirm the diagnosis. Now, if the non-treponemal test is negative and the individual has a history of treated syphilis, then no further evaluation or treatment is needed. If the individual doesn't have a history of treated syphilis, then a different treponemal test is done, and if it's reactive, then the diagnosis is confirmed. If it's negative, then the initial treponemal test is considered a false positive. Treatment of syphilis depends upon the stage. Early syphilis is treated with a single dose of 2.4 million units of intramuscular penicillin G benzathine. Alternatives include 100 milligrams of oral doxycycline twice daily or 500 milligrams of tetracycline 4 times daily for 14 days. Late syphilis is treated with 2.4 million units of intramuscular penicillin G benzathine, 1 injection weekly for 3 weeks. Alternatives include 100 milligrams of oral doxycycline twice daily for 4 weeks. Neurosyphilis is treated with either 3 to 4 million units of IV aqueous penicillin G every 4 hours for 10 to 14 days, or with 2.4 million units of intramuscular penicillin G procaine daily, plus 500 milligrams of oral probenecid 4 times daily for 10 to 14 days. Alternatives include 2 grams of IV ceftriaxone for 10 to 14 days. Next, there's human immunodeficiency virus infection, or HIV infection, which is divided into 3 stages. First, there's viral transmission, which is when the virus is transmitted through sexual intercourse, exposure to infected blood, or perinatal transmission. Then there's acute HIV infection, also called primary HIV, or acute seroconversion syndrome. This is when HIV antibodies are detected within the first weeks after infection. The individual can be asymptomatic or have symptoms like fever, lymphadenopathy, sore throat, rash, myalgia, arthralgia, diarrhea, and headache. Finally, there's chronic infection, which is subdivided into asymptomatic infection and early symptomatic infection. In asymptomatic infection, there's persistent generalized lymphadenopathy, meaning that there are enlarged lymph nodes involving at least 2 sites for more than 3 months. In early symptomatic HIV infection, there's recurrent or persistent oropharyngeal and vulvovaginal candidiasis, seborrheic dermatitis, and bacterial folliculitis involving Staphylococcus aureus. Next, there's acquired immune deficiency syndrome, or AIDS, which is defined by a CD4 cell count less than 200 cells per microliter, or by the presence of AIDS-defining conditions, such as opportunistic infections like pneumonia with pneumocystis jirovecii. Finally, there's advanced HIV infection, where the CD4 cell count is less than 50 cells per microliter. The diagnosis of HIV infection is made using several tests, such as enzyme-linked immunoassays. There are 4 generations of enzyme-linked immunoassays, and the most used is the 4th generation test, which detects both immunoglobulin G, or IgG, and immunoglobulin M, or IgM, and P24 antigen, which is a core antigen of the virus. There's also the Western blot, which detects both IgG and IgM antibodies. Finally, there's the HIV viral load test, which detects HIV RNA. Now, when HIV infection is suspected, testing is done using an immunoassay and a viral load test. If both come back negative, then there's no HIV infection. If the immunoassay test is negative and the viral load is positive, this suggests an acute or early HIV infection. If both immunoassay test and viral load test are positive, then this suggests an early infection or an established HIV infection. Treatment of HIV infection is done with a cocktail of antiretroviral medications and depends upon the stage, clinical presentation, viral load, and CD4 cell count. Finally, there are hepatitis B and C infections, which can cause acute hepatitis or chronic hepatitis. Acute viral hepatitis lasts for less than 6 months, and the individual has nausea, vomiting, and right upper quadrant pain. Sometimes, if there's a high total bilirubin, it can lead to jaundice, pruritus, dark urine, and clay-colored stools. Chronic viral hepatitis lasts for more than 6 months, and the individual can sometimes be asymptomatic. Other times, chronic viral hepatitis can cause fever, fatigue, and loss of appetite, as well as extrahepatic symptoms like arthralgias and skin rashes. In an active hepatitis B infection, the hepatitis B surface antigen is positive, and for hepatitis C, the anti-HCV immunoglobulin G antibodies are positive. Treatment of acute hepatitis B and C is mainly supportive, like maintaining good hydration and using antiemetic medications like metoclopramide. Treatment of chronic hepatitis B is done with antiviral medications such as pegylated interferon, entecavir, and tenofovir. Treatment of chronic hepatitis C relies on antiviral medications like sofosbuvir, velpatasvir, and decladisvir. Now let's talk about when STI screening should be done. First, there are some behavioral risk factors that increase the risk of STIs, such as new sex partners in the past 60 days, multiple sex partners or sex partners with concurrent sex partners, sexual contact with partners recently treated for STIs, lack of or inconsistent use of condoms outside a monogamous relationship, and sex work. Then there are high-risk groups that are associated with a higher prevalence of STIs as well as high morbidity with STIs, such as young age between 15 and 24 years old, history of prior STIs, males who have sex with males, HIV positive status, pregnant females, as well as illicit drug use and admission to correctional facilities. Generally, testing for HIV infection is recommended at least once in all individuals aged 13 to 75 years old. Now, since it's impractical and pretty expensive to screen all individuals with an active sexual life, screening is more recommended in individuals with risk factors or individuals that are in a certain risk group. For females under 25 years without risk factors, screening for genital chlamydia and gonorrhea is done once a year using NAT. For females under 25 years with risk factors, screening for other STIs is also done once a year. These include syphilis using RPR or VDRL, trichomoniasis using NAT, and hepatitis B using hepatitis B surface antigen. Screening for hepatitis C using anti-HCV antibodies is done if the female has a sex partner with a chronic hepatitis C infection. In this group, screening for cervical cancer, which is almost exclusively caused by HPV infection, is also done along with HPV vaccination, which is recommended up to 26 years old. For females above 25 years old and no risk factors, screening for cervical cancer continues. If there are any risk factors, then screening for genital chlamydia and gonorrhea, syphilis, trichomoniasis, and hepatitis B must be done once a year. As with the previous group, screening for hepatitis C is done if the partner is infected. Now, pregnant females are screened at the initial prenatal visit for HIV, hepatitis B, syphilis, and if they are younger than 25 years old, or if they have risk factors, then testing for chlamydia and gonorrhea is also done. For males that have sex with females, routine screening is not necessary. However, for males who have sex with females and have risk factors, screening includes searching for genital chlamydia and gonorrhea, syphilis, hepatitis B, and hepatitis C. For males who have sex with males with no risk factors, screening for genital and rectal chlamydia, genital and rectal gonorrhea, pharyngeal gonorrhea, syphilis, and HIV are done once a year. Additionally, screening for hepatitis B and hepatitis C are done at first visit, since their prevalence is higher in this group. For males who have sex with males with risk factors, screening for these STIs should be done every 3 months. Alright, as a quick recap, Neisseria gonorrhoeae, Chlamydia trachomatis, and Mycoplasma genitalium typically cause cervicitis and urethritis. Diagnosis is made using NAT. Treatment of Neisseria gonorrhoeae infection is done with 500 mg or 1 gram of IM ceftriaxone and 100 mg of doxycycline twice daily for 7 days if a chlamydia infection has not been ruled out. Chlamydia infections are also treated with doxycycline for 7 days, or a single 1 gram dose of azithromycin, or a 7-day course of levofloxacin. For Mycoplasma genitalium infections, empiric treatment is done with a 7-day course of doxycycline, followed by a 7-day course of moxifloxacin. Trichomonas vaginalis presents with vaginal or urethral discharge and is diagnosed using NAT. In females, treatment is done with a 7-day course of metronidazole, while in males, a single 2 gram dose of metronidazole can be given. Alternatively, a single 2 gram dose of tinidazole can be given to all individuals. Pediculosis pubis and Sarcoptes scabiei infections cause pruritus in the genital area, and with pediculosis pubis infection, Lice and nits are seen on the clinical examination, while with Sarcoptes scabiei, a microscopic examination of a skin sample may be necessary. Treatment consists of topical permethrin, oral ivermectin, or topical malathion lotion. HSV infection causes painful pustular ulcers in the genital area. Diagnosis is made using a viral culture or HSV PCR. Treatment depends upon the type of infection, and options include acyclovir, famciclovir, and valacyclovir. HPV serotypes 6 and 11 cause condylomata acuminata, or anogenital warts, which can be diagnosed clinically or by doing a biopsy. Treatment includes topical administration of imiquimod or cinecadekins. If the lesions persist, then surgical excision, electrosurgery, cryotherapy, or treatment with trichloroacetic acid can be done. Next, Treponema pallidum infection causes syphilis, which is divided into early and late stages. The early stage is further subdivided into primary syphilis and secondary syphilis. With primary syphilis, there's a chancre at the site of inoculation, and this heals within 6 weeks. Secondary syphilis is a systemic infection. Late or tertiary syphilis develops over years to decades after the initial inoculation. Neurosyphilis can occur at any time, and common findings include tabes dorsalis, confusion, and reduced concentration. In order to diagnose syphilis, non-treponemal and treponemal tests are used. Early syphilis is treated with a dose of IM penicillin G benzathine. Late syphilis is treated with IM penicillin G benzathine 1 injection weekly for 3 weeks. Neurosyphilis is treated with IV aqueous penicillin G for 10 to 14 days. HIV infection is divided into 3 stages: viral transmission, acute, and chronic HIV infection. To diagnose HIV infection, testing is done using an immunoassay and a viral load test. Treatment of HIV infection is complex. It depends upon the stage, clinical presentation, viral load, and CD4 cell count, and relies on antiretroviral therapy. Finally, hepatitis B and C infections cause acute or chronic hepatitis. To confirm hepatitis B infection, hepatitis B surface antigen is done and is positive. And for hepatitis C, the anti-HCV immunoglobulin G antibodies are positive. Treatment of acute hepatitis B and C is mainly supportive, and treatment of chronic hepatitis B and hepatitis C relies on antiviral medication.
"29-year-old Carmen presents to the physician's office complaining of severe lower abdominal pain during her menstrual periods, as well as pain during intercourse. She has been trying unsuccessfully to get pregnant for the first time for the past 2 years. Pelvic examination shows a normal-sized uterus. Later that day, 44-year-old Susanna comes to her physician reporting heavy menstrual periods that last about 10 days. This has been occurring for the past 6 months, and is accompanied with a feeling of fullness in the lower abdomen as well as fatigue. On further history, she has never been pregnant. Physical examination shows an enlarged uterus with multiple round masses. Laboratory studies reveal iron deficiency anemia. Based on the initial presentation, Carmen and Susanna both have some form of uterine disorder. So let's first review the physiology real quick. The uterus consists of 3 layers: an outer layer called the perimetrium, or the serosa, a middle smooth muscle layer called the myometrium, and the innermost layer, the endometrium. The endometrium itself has 2 layers: an inner functional layer made up mainly of glands and supporting connective tissue called stroma, and an outer thin basal layer which regenerates the overlying functional layer after each menstrual cycle. Okay, now the first uterine disorder is endometritis, or inflammation of the endometrium. This is usually caused by normal bacterial flora of the lower genital tract, meaning the cervix, vagina, or external genital organs that travel upwards into the endometrium. A high-yield risk factor to remember is the retention of products of conception, like parts of the placental or fetal tissues, following delivery or abortion. Another risk factor is the presence of a foreign body, like an intrauterine contraceptive device. Both can provide a good environment for bacteria to grow and cause an infection in the uterus. Less commonly, endometritis can be caused by outside bacteria such as Chlamydia trachomatis or Neisseria gonorrhoeae, which are transmitted sexually, or Mycobacterium tuberculosis, which spreads from the lungs into the blood and travels to other organs such as the uterus. Now, endometritis can be acute or chronic. On your test, an individual with acute endometritis typically presents with symptoms like fever, abnormal uterine bleeding, lower abdominal pain, dysuria, which is painful urination, or dyspareunia, which means pain during sexual intercourse. In contrast, in chronic endometritis, people often have no symptoms and a normal physical examination. However, some may experience similar symptoms to those of acute endometritis, although milder. Diagnosis of endometritis is usually based on clinical findings. An endometrial biopsy can help make the diagnosis, although that's not routinely done. What you absolutely have to remember is that microscopic examination of acute endometritis shows neutrophils in the endometrium, which are the hallmark of acute inflammation, while in chronic endometritis, the presence of lymphocytes, especially plasma cells, in the endometrium is diagnostic. When endometritis is caused by tuberculosis, an additional finding is the presence of granulomas in the endometrium, which is why it's also called chronic granulomatous endometritis. Treatment of endometritis is based on antibiotics. Next, there is Asherman syndrome. This occurs when the basal layer of the endometrium undergoes fibrosis, so it's unable to regenerate the functional layer. Sections of the normal tissue in the uterus are replaced by multiple bands of collagen, which lead to intrauterine adhesions, where the bands make the uterine walls stick to each other. This whole process causes the endometrium to fail to respond to hormonal stimulation, leading to amenorrhea, or the absence of menstrual bleeding. In severe cases, these fibrous bands can cover the whole uterus, causing infertility or recurrent pregnancy loss. Now, for your exams, it's important to remember that this typically occurs in a female who has undergone uterine instrumentation in the past, like dilation and curettage. Another uterine disorder that's high yield is endometrial hyperplasia. This is hyperplasia or excessive growth of the endometrial glands. What drives this process, in most cases, is long-standing increased exposure to estrogen without the counteracting effect of progesterone. For your exams, it's important to remember that this can be caused by a variety of conditions such as obesity, where the extra adipose tissue converts androgens to estrogen. It could also be caused by estrogen-secreting tumors, such as granulosa cell tumors of the ovaries. People with polycystic ovarian syndrome are also at risk of endometrial hyperplasia. In this condition, the ovary is full of cystic follicles that secrete estrogen. To make things even worse, these follicles don't ovulate most of the time, a condition known as chronic anovulation, so there's no luteal body to secrete progesterone. Now, a person could have normal estrogen production throughout their life, but the number of years the endometrium is exposed to estrogen is also a risk factor for developing endometrial hyperplasia. Estrogen exposure is increased in people who have an early menarche, which is the age of the first menses, or those that have a late menopause. This is because these people have experienced a greater number of menstrual cycles, where more follicles have grown, and more estrogen was secreted by these follicles. The same goes for females who have never given birth, also called nulliparous, who are at a higher risk than those who have been pregnant. That's because during pregnancy, there's more estrogen and progesterone production, but the balance shifts towards more progesterone, which is protective against endometrial hyperplasia. Also, we have medications that can cause endometrial hyperplasia, such as estrogen-only hormone replacement therapy, usually taken by postmenopausal females to relieve menopause symptoms, such as hot flashes and vaginal dryness. In some cases, endometrial hyperplasia can also be caused by tamoxifen, a breast cancer medication which blocks estrogen receptors on the breast. but at the same time stimulates those on the endometrium. The number one concerning problem with endometrial hyperplasia is that it increases the risk for endometrial cancer, which is the most common cancer arising from the female reproductive system. The risk of developing endometrial cancer depends on the histological features of the cells undergoing hyperplasia. So, zooming into a section of the endometrium, hyperplasia can be simple, where there's a lot of dilated glands and stroma, but their ratio is similar to normal tissue. In complex hyperplasia, there are way more glands and less stroma, meaning a high gland-to-stroma ratio, and this type of hyperplasia is more at risk of progression to endometrial cancer. If we zoom in even more, we can see the nuclei inside these glandular cells. Abnormal nuclear features like larger and hyperchromatic or darker nuclei are also called nuclear atypia, which for your test is the most important factor in terms of progression to endometrial cancer. Now, there are two main types of endometrial cancer. The most common one, accounting for about 75% of all cases, is type 1 endometrial carcinoma, which is also called endometrioid carcinoma. That's because the classic histology is endometrioid, meaning that the cancer cell looks very much like the normal endometrial cells. And this is the one that can arise from endometrial hyperplasia and is linked to prolonged unopposed estrogen exposure. Now, another risk factor is age, since this type of endometrial cancer typically presents in postmenopausal individuals around 55 to 65 years of age. In addition, a family history of ovarian cancer, colon cancer, or other gastrointestinal cancers can be a hint for an autosomal dominant disorder known as hereditary non-polyposis colorectal cancer, or Lynch syndrome, where you are also at a higher risk for developing endometrial cancer. Another high-yield fact is that type 1 endometrial cancer usually involves several genetic mutations in endometrial cells, including loss of PTEN, a tumor suppressor gene. This promotes growth and replication of endometrial cells, or enhances the expression of genes which are linked to estrogen receptors. Type 2 makes up the remaining 25% of endometrial carcinoma, and it has a number of subtypes. The most common subtype is serous carcinoma. Under the microscope, serous carcinomas often form papillary or finger-like structures. On biopsy, they often contain somoma bodies, which are circular plaques of calcium deposits around necrotic or dead cells. What you need to remember is that type 2 carcinomas don't appear to be linked with estrogen levels. In contrast, these cancers typically affect females with endometrial atrophy. Another important distinction is that they also tend to develop later in life than type 1, usually around the age of 70. However, they are more aggressive. For your exams, it's important to know that the genetic mutations found most often in serous carcinoma involve the TP53 gene, another tumor suppressor, and aneuploidy, or an abnormal number of chromosomes after cell division. Alright, let's talk about symptoms. Both endometrial hyperplasia and endometrial carcinoma typically present with menorrhagia, which means heavy or prolonged menstrual bleeding, metrorrhagia, bleeding between menstrual cycles, or a combination of both, known as menometrorrhagia. Both of these are usually painless. So a high-yield concept is that any painless vaginal bleeding in a postmenopausal female could be a sign of endometrial hyperplasia or cancer. If we're dealing with a more advanced endometrial cancer, there might be enlargement of the whole uterus, and if the tumor or tumors are large enough, this can cause abdominal pain and cramping. Diagnosing endometrial hyperplasia or cancer usually involves doing a transvaginal ultrasound to determine the thickness of the endometrium. Afterwards, a biopsy is used to confirm the diagnosis. Treatment for endometrial hyperplasia includes eliminating the underlying cause of excess estrogen, such as weight loss in cases of obesity, stopping unopposed estrogen therapy, and correcting the problem of anovulation in cases of polycystic ovarian syndrome. Also, progesterone-containing medications can be used, which help in counteracting the proliferative effect of estrogen. For endometrial cancer, treatment is based on surgery. This typically means the removal of the uterus, both ovaries, and both fallopian tubes, also called a hysterectomy with bilateral salpingo-oophorectomy, combined with the removal of pelvic and para-aortic lymph nodes. In some cases where the cancer is more advanced or is likely to spread, radiation therapy and/or chemotherapy can also be done after surgery. Okay, next, endometrial polyps are benign growths of the endometrial glands and stroma that protrude into the uterine cavity. What's especially high yield is that they're more frequent in females who are on tamoxifen therapy. So, in your test question, the typical individual with endometrial polyp will also have a history of breast cancer treatment. Now, endometrial polyps may be asymptomatic or present with abnormal uterine bleeding. Diagnosis involves a transvaginal ultrasound, which can help identify the polyp. And then treatment requires a hysteroscopy, which is done to remove it. Okay, moving on to endometriosis. This is when endometrial tissue migrates outside the endometrial cavity and implants themselves in other parts of the body. Although we're unsure of why this happens, the most common theory is retrograde menstruation. Right, now basically this suggests that during menstruation, some blood carrying endometrial cells will flow backwards into the fallopian tubes and implant into nearby tissue. But alternatively, the metaplastic theory suggests that cells of the peritoneum, which come from the same cell line as endometrial cells, can transform spontaneously into endometrial tissue. And then there's also the benign metastases theory, which says that endometrial cells can travel to distant organs through the lymph and blood. In any case, once there, endometrial cells will set up camp and start growing to form a mass of endometrial tissue. For your exams, it's important to know that most often this affects the ovaries bilaterally, which classically results in formation of a blood-filled chocolate cyst. But it can also affect other structures in the pelvis and abdomen like the fallopian tubes, the uterine ligaments, the rectouterine pouch, also called the pouch of Douglas, and even the bladder or the intestines. Another high-yield fact is that these implants classically appear grossly as yellow-brown gunpowder nodules. Now, symptoms of endometriosis are related to the location of the endometrial cells. Most commonly, endometriosis on the reproductive organs will cause pelvic pain, bleeding, dysmenorrhea, or painful menstruation, and dyspareunia, or painful sexual intercourse. If it involves the pouch of Douglas, it can cause dyschezia, or pain with defecation. It can also cause urgent, frequent, and sometimes painful urination if it involves the bladder, and abdominal pain if it involves the intestines. The most important thing to keep in mind is that all of these symptoms will often vary with the hormone changes throughout the menstrual cycle, and often gets worse during menstrual periods. Another high-yield fact is that fertility problems are especially common in individuals with endometriosis. The exact link, again, is unclear, but it's believed that the inflammation that comes with endometriosis can damage or scar the ovaries, or fallopian tubes, thus inhibiting the release of the egg or its movement during ovulation. Damage to the uterus can also make the implantation of the gamete more difficult. Okay, now diagnosis starts with pelvic examination, where it's important to remember that the uterus will be normal-sized. This is followed by laparoscopy, and confirmed with a biopsy. Treatment is focused on managing pain, trying to limit the progression of the implants, and addressing the associated subfertility. Common medications that are used to treat pain include combined estrogen-progesterone oral contraceptive pills, which relieve pain through ovarian suppression, progesterone analogs like medroxyprogesterone and levonorgestrel, which inhibit growth of the endometrium, danazol, which is a steroid that inhibits mid-cycle surges of follicular-stimulating hormone and luteinizing hormone, and gonadotropin-releasing hormone modulators, which cause a decrease in estrogen levels. Surgical options are available for severe cases. If the person still wants to have children, the surgery involves only excision of endometrial implants endometriomas, and adhesions. If the person has completed their childbearing, or if the pain is too debilitating, a hysterectomy and oophorectomy, which is removal of the uterus and ovaries along with excision of any other endometrial implants, is done. Whatever the treatment, it's also important to remember that once menopause hits and hormone levels fall, the symptoms generally go away. Adenomyosis is a specific form of endometriosis in which endometrial tissue develops ectopically in the myometrium. Once again, this ectopic endometrial tissue responds to hormonal changes throughout the menstrual cycle, just like the endometrium inside the uterine cavity. So, with adenomyosis, there's typically dysmenorrhea, or painful menstruation. Heavy menstrual bleeding and chronic pain may also be present. Unlike other forms of endometriosis, remember that on physical examination, the uterus will be uniformly enlarged, globular, and boggy, meaning soft on palpation. Another tricky thing is that the only definitive diagnosis for adenomyosis is histopathological analysis of the uterus after hysterectomy. However, hysterectomy is only recommended in individuals who have completed childbearing. If the individual wishes to have children in the future, symptoms are usually managed with hormonal medication, like combined oral contraceptives and gonadotropin-releasing hormone modulators. Okay, next, leiomyomas, also known as uterine fibroids, are benign tumors of smooth muscle. In fact, they're the most common gynecological tumor. They can be classified based on where they are located in the uterus. For your exams, remember that they are the most common type of intramural fibroids, and they develop within the wall of the uterus. Subserosal fibroids come from smooth muscle cells at the perimetrium. Submucosal fibroids come from smooth muscle cells just below the endometrium, and they can grow into the cavity of the uterus and change the shape of it. When that happens, they're called pedunculated fibroids. Fibroids most commonly affect individuals of African descent. They're related to estrogen exposure, so the more estrogen available, the more a fibroid is likely to grow. This is why fibroids typically affect premenopausal females between the ages of 20 and 40, and why they grow rapidly during pregnancy when there's a lot of estrogen around, and shrink with menopause. Another risk factor for developing a fibroid is being nulliparous, early menarche, and late menopause, just like the risk factors for endometrial hyperplasia. Now, a high-yield fact is that the fibroids most commonly develop in groups, although they can sometimes be solitary. Fibroids are usually small and asymptomatic, but large or numerous fibroids can cause symptoms like abnormal uterine bleeding in the form of menorrhagia or metrorrhagia. Over time, this can lead to iron deficiency anemia in a premenopausal female. Fibroids can also cause abdominal pain or a feeling of fullness by putting pressure on pelvic organs. Submucosal and intramural fibroids in particular are also associated with infertility and a higher risk of miscarriage. In pregnancy, fibroids can also cause issues such as fetal malpresentation, preterm labor, and postpartum hemorrhage. Diagnosis starts with a pelvic exam, which usually reveals an enlarged uterus with multiple palpable round masses, followed by an ultrasound. Rarely, a biopsy of the mass is done. On gross examination, these are round, firm, and grayish-white in color, usually without any necrosis or hemorrhage. And a high-yield fact for your test is that microscopic examination will classically show a whorled pattern of smooth muscle bundles, like a wave in the ocean, with well-defined borders. Treatment of uterine fibroids varies. Asymptomatic uterine fibroids are usually left untreated, while symptomatic fibroids can be treated with surgery, either a myomectomy or a hysterectomy or uterine artery embolization, where a catheter is used to reduce blood flow to the fibroids and causes them to shrink. Finally, the last type of uterine disorder is leiomyosarcoma, which is a very rare, malignant tumor of smooth muscle arising from the myometrium. The most important thing to remember here is that it arises de novo, or on its own, meaning that leiomyomas do not progress into leiomyosarcomas. Another key fact is that unlike leiomyomas, which most commonly affect premenopausal individuals and go away after menopause, leiomyosarcomas usually develop in postmenopausal individuals. Symptoms are typically similar and may include abnormal uterine bleeding and abdominal or pelvic pain or pressure. Diagnosis includes an ultrasound and a biopsy of the mass. What's high yield here is that unlike leiomyomas, which are usually multiple and gross examination shows no necrosis or hemorrhage, leiomyosarcoma is classically a single lesion with necrosis and hemorrhage. Microscopic examination of a leiomyosarcoma reveals increased mitotic activity and cellular atypia. Treatment is surgical and may be combined with chemotherapy or radiotherapy. All right, as a quick recap. Endometritis refers to the acute or chronic inflammation of the endometrium due to invasion of bacteria normally found in the lower genital tract. Asherman syndrome involves intrauterine adhesions following procedures like dilation and curettage and can result in amenorrhea, infertility, or recurrent pregnancy loss. Endometrial hyperplasia is the excessive growth of the endometrial glands, most commonly caused by long-standing increased exposure to estrogen without the counteracting effect of progesterone. Endometrial hyperplasia carries a risk of progression into endometrial cancer, depending on the histological findings. Endometrial carcinoma has two types. Type 1 is usually preceded by endometrial hyperplasia. Type 2 isn't linked with estrogen levels, is usually associated with endometrial atrophy, and is more aggressive than type 1. The most common symptom of both endometrial hyperplasia and cancer is abnormal vaginal bleeding after menopause. Endometrial polyps are benign growths of the endometrial glands and stroma that protrude into the uterine cavity and are commonly associated with tamoxifen therapy. Endometriosis refers to the presence of endometrial tissue outside the endometrial cavity, usually on the ovaries, causing pelvic pain and bleeding that gets worse during menstruation. A specific form of endometriosis is adenomyosis, in which there is endometrial tissue inside the myometrium. Leiomyomas, or uterine fibroids, are extremely common benign smooth muscle tumors that usually develop in premenopausal individuals in response to estrogen and can present with abnormal uterine bleeding, pain, iron deficiency anemia, or fertility issues. Leiomyosarcomas, on the other hand, are malignant tumors of the smooth muscle that develop de novo in postmenopausal individuals. All right, and it's been a little while, but let's not forget about our cases. Carmen came in with dysmenorrhea and dyspareunia that got worse during menstruation, as well as fertility issues, but a normal-sized uterus on pelvic examination. This is a classic presentation of endometriosis. Indeed, laparoscopy showed bilateral chocolate cysts in the ovaries, which were biopsied to confirm the diagnosis. On the other hand, Susanna presented with menometrorrhagia, a feeling of abdominal fullness, an enlarged uterus with multiple round masses, and iron deficiency anemia, which are all characteristic for leiomyomas. Other clues include that she's premenopausal and nulliparous, which are both related risk factors. This was confirmed by ultrasound and biopsy, where gross examination showed round, firm, and grayish-white lesions without any necrosis or hemorrhage, and microscopic examination revealed a whorled pattern of smooth muscle bundles with well-defined borders.
"62-year-old Tess comes to the emergency department with vaginal bleeding for the past couple of hours. She also mentions that she has occasionally noticed some watery, foul-smelling vaginal discharge. After ensuring that she is hypodynamically stable, history reveals that her last menstrual period was about 10 years ago, and she has had multiple sexual partners. On speculum examination, A suspicious-looking mass is identified in the upper third of the posterior vaginal wall. Later that day, 69-year-old Ocean comes to the physician's office complaining of an intense burning sensation, itching, and pain in her genital region. Her last menstrual period was at the age of 48. On further history, she has been smoking 1.5 packs daily for 40 years. On examination, a white, asymmetrical lump with irregular borders and a 1.2 centimeter in size is seen in the right labia majora. Alright, both Tess and Ocean have some type of vaginal or vulvar condition. Let's take a look at the anatomy real quick. The external sex organs, together referred to as the vulva, contain the labia majora, which covered the labia minora, and between the two labia minora there is a space called the vulvar vestibule that includes the opening of the vagina and the urethral opening. Now, vaginal and vulvar conditions are classified into non-neoplastic ones, including Bartholin's cyst, lichen sclerosus, lichen simplex chronicus, and imperforate hymen and neoplastic ones, which are relatively rare cancers of the female genital tract. Okay, let's start with the first non-neoplastic condition, which is the Bartholin cyst. The Bartholin glands are two small glands that lie underneath the vestibule and on each side of the vaginal opening. Normally, they secrete a mucus-like fluid that drains through ducts into the vestibule in order to lubricate the vagina, but when their ducts get blocked, the fluid builds up, causing cystic dilation of the gland. For your exams, remember that blockage typically occurs in females of reproductive age as a result of a mucus plug or a sexually transmitted infection, and especially Neisseria gonorrhea. If the cyst itself gets infected, an abscess occurs. Now, in a test question, a Bartholin cyst typically presents as a unilateral cystic lesion at the lower vestibule adjacent to the vaginal canal. Most small cysts are not painful, but very large cysts can cause significant pain, and in the case of an abscess, the site will be red, warm, swollen, and extremely painful. Diagnosis is clinical, and treatment is drainage of the cyst or opening the cyst to create a pouch, called marsupialization. Next, there's lichen sclerosus. What's high yield about this is that there's thinning of the epidermis with sclerosis or fibrosis of the underlying dermis. This usually occurs in the genital or anal regions and is more common in postmenopausal individuals. Now, the reason why lichen sclerosus develops is unknown. A key principle is that although it is benign, for unclear reasons, it's associated with a slightly increased risk for squamous cell carcinoma. It classically presents with leukoplakia, which is a porcelain white plaque with a red or violet border. And the epidermis is so thin that examiners often like to describe it as with the phrases like cigarette paper or parchment-like. That thin epidermis is also very fragile, so skin erosions can be present. Symptoms typically include vulvar itching and sometimes dyspareunia, or painful sexual intercourse. Diagnosis is clinical, and treatment may include steroid ointments to reduce itching. A sort of opposite condition is lichen simplex chronicus. In this case, there is hyperplasia of the vulvar squamous epithelium as a result of chronic irritation or scratching. It's more common in individuals between the age of 30 and 50. For your exams, what's high yield is that it's totally benign, and unlike lichen sclerosus, carries no risk for squamous cell carcinoma. Presentation is again with leukoplakia, but in this case, the key is that the vulvar skin is thick and leathery. For symptoms, there's an itch-scratch vicious cycle, where itching leads to scratching and hyperplasia, which results in more itching. Diagnosis is clinical, and treatment may include steroid ointments to reduce itching. The last non-neoplastic condition is an imperforate hymen, which is a congenital disorder where a hymen without an opening completely blocks the vaginal opening. This is caused by a failure of the hymen's central epithelial cells to degenerate during fetal development. At birth, it may cause vaginal mucus to build up, causing the hymenal membrane to bulge outwards. That's usually self-resolving though. So for your exams, it's important to know that imperforate hymen typically presents in adolescent females when menstrual blood accumulates in the vagina, which is also known as hematocolpus. A test question might sometimes also show a characteristic picture of a bulging bluish hymenal membrane, and since menstrual blood can't go through, there's primary amenorrhea. However, these individuals do have recurring menstrual cramps and abdominal or pelvic pain without any outward signs of bleeding. On ultrasound, hematocolpus will be visible. Treatment is with surgical incision of the hymen. Okay, now moving on to the neoplastic conditions. Let's begin with vaginal cancer. There are three main histologic subtypes. The most common is squamous cell carcinoma, which develops from the squamous epithelium of the vagina. A very high yield fact to know is that it's linked to HPV infection. Particularly high risk strains include HPV 16, 18, 31, and 33. It's also helpful to remember these can also cause cervical cancer. In fact, vaginal squamous cell carcinoma is frequently secondary to metastasis from cervical squamous cell carcinoma. And just like cervical cancer, vaginal cancer can start out as vaginal intraepithelial neoplasia, and it may take many years for it to even progress to cancer. So, it predominantly occurs in postmenopausal females over the age of 60. Now, for your test, it's important to know that the strongest risk factor is multiple sexual partners, followed by early age at first sexual intercourse, smoking, and immunocompromising conditions like an HIV infection. The second, more rare type is clear cell adenocarcinoma, which develops from the glandular cells of the vagina. A high-yield fact is that unlike squamous cell carcinoma, it most commonly affects young individuals under the age of 20, and it's almost always linked to in utero exposure to a medication called diethylstilbestrol, or DES for short, which is no longer in use. So the test question will typically describe a female whose mother was prescribed DES during her pregnancy to prevent premature labor or miscarriage. Next, there's botryoid rhabdomyosarcoma of the vagina, also known as sarcoma botryoids. This is extremely rare, but high yield for your exams and develops from rhabdomyoblasts, or immature skeletal muscle cells lining the walls of the vagina. It most commonly affects individuals under the age of 4. For symptoms, vaginal cancer most often causes postcoital or postmenopausal vaginal bleeding. A watery, blood-tinged, or foul-smelling vaginal discharge might also be present. Now, in the later stages, when the cancer is spread further and invades into organs like the bladder, there may also be symptoms like urinary frequency, dysuria, and hematuria. If the cancer is spread to the rectum, there may be constipation. The cancer cells can also metastasize to the lymph nodes, in which case pelvic pain can be present. Very important to know for examination purposes is that the region of lymph nodes where cancer spreads depends on the location of the tumor in the vagina. So, tumors from the lower 2/3 of the vagina will go to the inguinal lymph nodes, while tumors from the upper 1/3 will go to the nearby iliac nodes. Now, diagnosis starts with the speculum examination. Most commonly, vaginal cancer looks like a mass, but it can also look like a white plaque or an ulcer. In the case of sarcoma botryoids, it's important to know that the mass is polypoid and protrudes through the vagina. The key phrase here is that the mass resembles a bunch of grapes. In all cases, remember that vaginal cancer typically originates from the upper third of the posterior vaginal wall. To confirm the diagnosis, when there is a vaginal mass, a biopsy is done. When there is no mass, vaginal cytology can be done. This is frequently combined with HPV genotyping, meaning the vaginal cytology sample is analyzed for the presence of high-risk HPV DNA. Now, the biopsy results can differentiate between squamous cell carcinoma, clear cell adenocarcinoma, and sarcoma botryoids. For squamous cell carcinoma, the biopsy can also distinguish between precancerous lesions, like vaginal intraepithelial neoplasia or invasive vaginal cancer. Vaginal intraepithelial neoplasia, or VANE for short, is classified based on how much of the vaginal epithelium is affected. Vein 1 is when only the lower 1/3 of the epithelium contains cancer cells. Vein 2 is when the lower 2/3 are affected, and vein 3 involves more than 2/3 of the epithelium. Carcinoma in situ is when the entire epithelium is made up of cancer cells, and it's included in the vein 3 category. And invasive vaginal cancer is when the cancer cells have breached through the basement membrane. Now, for sarcoma botryoids, what's important to remember is that biopsy will reveal rhabdomyoblasts, usually described as spindle-shaped cells with cytoplasmic cross-striations. And on immunohistochemistry staining, these cells will stain positive for desmin and myoglobin. Finally, imaging with CT or MRI scan can then be done to look for evidence of metastasis. Now, treatment usually consists of local surgical excision or ablation of the lesion, or, in more advanced cases, a radical hysterectomy and vaginectomy or surgical removal of the whole uterus and vagina, along with the associated lymph nodes, might be necessary. This is followed by chemotherapy and radiotherapy if the tumor has metastasized. Moving on to vulvar cancer, there are 3 main histologic subtypes. So for your test, remember that over 90% of vulvar cancers are squamous cell carcinomas, which develop from the squamous epithelium of the vulva. Just like cervical and vaginal squamous cell carcinomas, these are usually linked to high-risk HPV strains like 16 and 18. It can start out as vulvar intraepithelial neoplasia and most commonly present in postmenopausal females. Risk factors for HPV-related squamous cell carcinomas once again include multiple lifetime sexual partners, early age at first sexual intercourse, smoking, and immunocompromising conditions. Rarely, squamous cell carcinomas are not related to HPV infection, and in this case, they usually arise from long-standing lichen sclerosis. Now, the other 10% of vulvar cancers are melanomas and vulvar adenocarcinomas. Melanomas develop from melanocytes, and risk factors include a family history of melanoma, or a personal history of melanoma, or dysplastic nevi, which are atypical moles in other locations on the body. Vulvar adenocarcinomas, on the other hand, develop from glandular cells, like those that make up Bartholin's glands on either side of the vaginal opening. Next, we have Paget disease of the vulva, which is a particular type of intraepithelial or in situ adenocarcinoma, meaning that cancer cells have not invaded the basal membrane. This is a type of cancer that usually develops in the ducts of the breast, but can rarely develop in other locations, such as the vulva. Now, a key difference is an individual with Paget disease of the breast will almost always have cancer somewhere else in the body. In contrast, in Paget disease of the vulva, there is usually no other cancer. For symptoms, vulvar cancer most often presents as an itchy leukoplakia, but may also look like a wart and vary in color, shape, and size, or an open sore that doesn't heal. A clue examiners often like to use is that the lesion is asymmetric, has irregular borders, and large size. Sometimes there may also be associated pain, bleeding, or discharge. In the case of Paget disease of the vulva, the test question will typically present an erythematous pruritic crusting ulcer. In later stages, if the cancer has metastasized to lymph nodes in the groin, these might also be enlarged and sometimes cause pelvic pain. To diagnose vulvar cancer, a biopsy is done. This can confirm the malignant character of the lesion and also differentiate between the different histologic subtypes. Immunohistochemistry is also frequently performed. So, for example, Paget disease of the vulva will stain positive for PAS and keratin, which are specific for epithelial cells, and negative for S100. In contrast, melanoma will stain negative for PAS and keratin, and positive for S100, which is specific for melanocytes. And that's a popular way for examiners to clue you in these particular types of tumors. Treatment usually involves local surgical excision or ablation of the lesion, or in more severe cases, surgical removal of the vulva or radical vulvectomy is required. This is followed by chemotherapy and radiotherapy if the tumor has metastasized. Alright, as a quick recap, non-neoplastic vaginal and vulvar conditions include Bartholin's cysts, where a blockage of the Bartholin's gland duct results in cystic dilation and may lead to an abscess, lichen sclerosis, which is a benign condition characterized by thinning of the epidermis and sclerosis of the dermis. It also increases the risk of developing squamous cell carcinoma. Lichen simplex chronicus is hyperplasia of the vulvar epithelium, but it doesn't raise the risk of carcinoma. Finally, there's imperforate hymen, which classically presents as primary amenorrhea with hematococcus. Now for vaginal cancers, there's squamous cell carcinoma, which is the most common type. It's usually HPV related and affects postmenopausal females. Clear cell adenocarcinoma is caused by in utero exposure to diethylstilbestrol. Sarcoma botryoids consist of grape-like tumors and usually present in individuals under the age of 4. Next, over 90% of vulvar cancers is squamous cell carcinoma, which are also HPV related and affect postmenopausal females, but can be also secondary to lichen sclerosis. The other 10% of vulvar cancers are either melanomas or adenocarcinomas, and a particular type of intraepithelial adenocarcinoma is vulvar Paget disease. Unlike Paget disease of the breast, it's usually the only cancer found in the individual unless there's metastasis. Okay, back to our cases. Tess presented with abnormal postmenopausal vaginal bleeding along with occasional watery, foul-smelling vaginal discharge. This is a classical presentation of vaginal cancer. Other clues include her age and the fact that she's had multiple sexual partners, which are strong risk factors for this type of cancer. On speculum examination, a mass was identified in the upper third of the posterior vaginal wall, which is the number 1 location for vaginal cancer. Biopsy of the mass revealed the squamous cell carcinoma, which is the most common type of vaginal cancer. On the other hand, Ocean came in with vaginal burning, pruritus, pain, and an asymmetric, irregular, large lump in her vulva, which all makes us suspicious of vulvar cancer. Her age and heavy smoking history are also risk factors. The lesion was biopsied and results came back with a diagnosis of squamous cell carcinoma of the vulva, the most common type of vulvar cancer.